All right, so I think I got this all set up correctly with the recording here. I know a lot of people have their OSCE this weekend. I assume, at least down here, I assume y'all had yours already, or it's tomorrow. For those that didn't have it, everyone got a psych in my term, so you have to know the MMSE. And then, yeah, I think a lot of people got an MSK or some sort of neurological problem was the other thing. It was fairly straightforward. Okay, as for this, we'll do neuro today. I pulled out 15 lectures. Most of them are drug lectures. A lot of them are stuff you should have seen already. And then we'll go through the MSK and infection stuff tomorrow. Figured it'd be easier for everybody to just break it up. Unfortunately, a lot of these drugs, especially the antibiotics, there's not much I could help you with. I'll point out some things that that were a bit. Hey, Catherine, your mic's on. No worries. Okay, so as for the drugs, like I'll point out some things that that keep coming up. So my step is in 3 weeks, so I've just been doing a ton of UWorld questions. So I will try to reiterate some things that are coming up over and over again, some very testable facts. But as for like the antibiotics, there's not much I can really help with. I'll just point out some of the things that were highly tested. I can say that I found that week of antibiotics probably one of the most stressful weeks of med school, but I was pleasantly surprised with the exam. I know y'all had a rough IMCQ, 1 or 2 recently, but I did feel like the exam was more than fair. Like they could have made it a lot harder. So if that puts you at ease at all, hopefully it does. So anyway, so we'll go ahead and get started. We'll do some of the neurologic stuff. Yeah, let's see. All right, and I don't have host privileges. I can't mute people. So yeah, I'll let you know if your mic's on. All right, anyway. Let's see. All right. So we'll go kind of quick. Crystal, I think your mic might have came on. We'll go quickly through some of these antidepressants. You should have seen most of these already. So one of the big things, always you don't want to prescribe some sort of antidepressant to someone with bipolar symptoms or a history of bipolar disease, because that could exacerbate the manic symptoms, right? So you never want to give somebody with any sort of history of mania, like a SSRI or whatnot. That being said, you all know by now SSRIs are first line for a lot of these depression symptoms or depression classifications. One of the big side effects that people come up in with is decreased libido. So typically they'll switch them from a SSRI to bupropion. That's usually the first thing they switch them to. Bupropion has a very unique characteristic in that it has dopamine agonistic properties. It's very unique in that sense. But being that it's not a SSRI or has serotonin antagonistic properties, you can avoid the issues with sexual dysfunction. All right, this was just some sort of hypothesis. Here we go. All right. Let's see. Here we go. All right. Yes, and and it's very important. These antidepressants, when patients come in a couple weeks in and they're saying they're not having a lot of, they don't feel very different. That's because it takes a little while for these drugs to start working. It does have that other beneficial effect in that they're not easily abused, right? Because they take so long to kick in. All right, the MAOIs, the big thing about these that you want to remember is the fact that they have that cheese reaction, that tyrosine reaction, tyramine reaction that comes up. So if anyone is eating cheese, this cheese reaction, it can cause these side effects to come about. Also serotonin syndrome. Remember, anytime you see something with flushing, diarrhea, stuff like that, I usually think of serotonin as the issue. Those are kind of the unique characteristics that kind of fall into serotonin, where a lot of things will have tachycardia and whatnot. If there's some sort of flushing, diarrhea, I usually lean on that. Let's see. Yeah, let's go back on. Even if it's bad enough, you can get hypothermia, muscle rigidity, and myoclonus as well, right? Okay. Let's see. Sedation with benzodiazepines and a serotonin antagonist. This is a great drug to know because there's only one, right? So this is the one thing you would give in the setting of serotonin syndrome, cyproheptadine. Okay, so definitely make sure you know that one. And then tyramine, this cheese reaction that happens, you have to make sure the patients know that that could happen. This can they can't degrade tyramine, so you get this release of catecholamines. Okay, so you get those sympathetic type response. Okay, even pseudoephedrine and pseudoephedrine is probably the only one they'd ask about. It's contraindicated here because they have sympathetic type properties, right? Alpha 1 type properties. So you have to be careful with that because MAOIs won't degrade this either. So you get too much of that in your system. But if I had to bet money, and if they had a question on this, they would ask about the cheese reaction. It's just one of those unique things about it. Treatment, yeah, I don't know. Yeah, they may ask about this, but probably not. There's so much to do. You kind of have to pick your battles here, what you really need to know. As for UWorld, I don't know how much you guys have done, but there's a ton of TCA questions just because there's so many side effects. The side effect profile for these is exhaustive. Not only do you get antihistaminic effects, you get anticholinergic effects, right? With these TCAs because of the anticholinergic effects. It also causes some heart toxicity. It causes QRS and QT prolongation. So you could end up, that's usually how the patients die if they take an overdose of TCAs. But you're going to want to make sure you know these side effects for that because it does come up a lot. Right, and you can see that here. Specifically fast sodium channels, not sure they'll ask you about this, but STEP definitely will. Like I said, this is typically how these patients die. Antihistaminic effects, okay, you know those, and muscarinic effects, and these alpha adrenergic effects. So you actually get bradycardia here. I think I said tachycardia, but you're actually going to get bradycardia because this blockade, you get orthostatic, I was right the first time. Orthostatic hypotension and reflex tachycardia, because remember these alpha 1 receptors are only on the vessels, right? Where beta 1s are on the heart. These alpha 1s are only on the vessels, so you get this. So if you have an alpha 1 effect, you would get vasoconstriction, but because these are blocking these alpha 1 receptors on the vessels, you get hypotension, so you will get that reflex tachycardia. And then of course you will go ahead and get these antimuscarinic or anticholinergic effects. Blurred vision, urinary retention, constipation, that's usually what they'll go with there. And then blockade of the H1 receptors, antihistamines, you take for sleep, so that causes sedation. And then very importantly, these fast sodium channels can lead to arrhythmias. Like I said, they may even go into the fact that they cause that QT prolongation. If you do that, you could end up getting supraventricular tachycardias in between, right? So if you extend that the potassium repolarization, you can get premature ventricular beats in between, which leads to like torsades de pointes and stuff like that. Anyway, so if you get these sort of side effects, and then you get some sort of cardiotoxicity, think TCAs. Okay. Sodium bicarb. That's exactly what you want to give if specific to the blockade of those sodium channels. Okay, so when you get that, sodium bicarb can be given, and that'll save the patient's life. It's not going to affect any of the other side effects, but in regards to that cardiac toxicity, that's what you're going to want to use. Okay, SSRIs. We mentioned this. These are your safe ones you want to give first line, even for general anxiety and stuff like that. This is first line. PTSD. This is first line. They're safe drugs. They're not really abusable, as I said. They take a while to kick in. So opposed to going straight to a TCA, which has all these side effects, you can just give one of these, right? At least when you start. As I mentioned earlier, the biggest side effect with these is the decreased libido, sexual dysfunction. Usually they take the patient off of this and give them bupropion, right? Because bupropion doesn't really mess with serotonin at all. All right, let's see. Yeah, that's the big one. They're going to ask you about this diminished sexual function. Don't think they got into this. Again, like I said earlier, you kind of got to pick your battles with all these drugs. So I don't really think they went into this in too much detail. All right. SARIs, trazodone is more of like something you give, something for sleep. So these are a little bit different. They have antagonistic properties, but are reuptake inhibitors specifically at that serotonin 2 receptor. Okay, so you can actually use those for sleep as well. Priapism, very unique reaction with trazodone, and because it does block these H1 receptors, it can give sedating or hypnotic effect. Okay, I don't remember them ever talking about this. I don't even know what the trade name is for this, but this is fairly common. SNRIs, okay, venlafaxine, duloxetine, same principle here, but you're also adding norepinephrine. Again, usually you start with an SSRI. You could use one of these instead. Kind of depends on what options you have in the question, right? The choices they give you. Let's see, and here we go. Bupropion, specifically norepinephrine and dopamine uptake, right? So they're very different here, where the other ones prevent their reuptake. This is going to inhibit the uptake and will increase the dopamine release. So it's very unique in that characteristic. So because it has no serotonergic effects, you don't have to worry about that sexual dysfunction. Okay. Let's see. Mirtazapine is very unique. It has it works on those alpha 2 receptors, which we don't talk a lot about, but it's an antagonistic there. So you can give it for sleep as well, used for insomnia. I think Remeron is the trade name for that, but yeah, that's just very unique in that it's the alpha 2 receptors. Let's see. Yeah, remember when you get these patients off it, you need to wean them off of this, okay, so you don't get some sort of discontinuation syndrome. Right, so incidence more likely with a shorter half-life, right, so you need to taper them off very slowly, especially with these. Again, I don't really think they tested on this because there were so many drugs to worry about. This is very busy for me, so I don't really look at that. Again, very busy. Yeah, but if you want to just kind of test yourself and see some of the big things there, just remember those TCAs are pretty gnarly. A lot of effects, antihistamine, anti-muscarinic effects. Yeah, so be careful with that. Orthostatic hypotension, because it has that alpha anti-1 effect, but you get that reflex tachycardia as well. Okay. Remember, it also has cardiac effects as well. We give sodium bicarb to treat that for TCA overdose. Okay, so patient comes in with those anti-muscarinic or anticholinergic effects, and you get heart problems. Think TCAs, and yeah, you can go from there. All right, let's see. Yes, first choice again: general anxiety, PTSD, panic disorder, OCD. Unless it's some sort of short-acting panic problem that you can give some sort of benzodiazepine for. If it's long term or throughout the day or whatever, generalized anxiety, you want to go ahead and try to give antidepressants. These SSRIs do have anxiolytic effects as well. So, and you can see this here, bupropion, though it can help with those side effects from the SSRIs, you know, less effective in the anxiety department. Okay. Chronic pain, this comes up too. TCAs and SNRIs, especially neuropathic pain, doesn't seem intuitive, but it does specifically have to do with this I think more the norepinephrine effect than the serotonin effect. Okay, so the fact that it blocks these this norepinephrine reuptake. If you remember how those opioids work, it does have this property to where this norepinephrine comes in and helps with the blocking effect. So this can actually help with neuropathic pain. Okay, and you can see premenstrual problems, SSRI, smoking cessation, bupropion has been proved. All right. Now, when we get to bipolar disorder, lithium is the first thing, usually what they ask about. It has very unique side effect profile too, but if there is any sort of manic depressive symptoms or sign of bipolar disorder, lithium is going to be pretty much your first choice. This was the first time I had really looked at, this lecture was the first time I had really looked at how lithium actually works. I don't think they really got into it too much on the exam, but it's very unique in its properties here. But I won't get into it. I don't think it was tested. So again, here's the side effects. Very important: neurogenic diabetes insipidus. So the patient will come in with very dilute urine, very concentrated serum. That's because they have a problem with ADH. And that's not exactly ADH, but the receptors to ADH. Okay. Right, so you can't. They'll be always thirsty. So you need to look at that. Hypothyroidism is another one that lithium can cause. So look for weight gain, sluggishness, bradycardia, cold intolerance, things like that. Okay, some of these other ones aren't as tested, but these two definitely are. And it kind of goes into it here, but definitely watch out for that because they won't specifically tell you it's an ADH or it's a nephrogenic DI problem, but just tell you the symptoms, and you need to pick up that it's lithium. Okay. Alternatives here, yeah, so you can give some of those anti-epileptics. Sure, they also have their own issues in and of themselves, but if you need to, you can go that route, but we'll talk about those when we get there. All right. Sorry, I'm like recording through my computer now, so it's taking its time. All right. All right. So, right. Remember we'll go quickly through these symptoms. Remember these schizophrenia symptoms. It's going to go through. Okay. I believe you have to have one of the first three. It should say it somewhere. It's hallucinations, delusions, or I thought it had something to do with speech. There should be a better slide for it. And then it has like withdrawal symptoms as well. This is a broader definition of it, but I think diagnostically it's hallucinations, delusions, or pressured speech are the first three, and then so you have to have one of those three, and then it's like disorganized behavior was the other one, and then mood symptoms is more of the negative effects of that. So, but y'all could double check me on that. All right, so you need to know this because these are kind of the drug targets, how it works. So the positive symptoms go through the mesolimbic system, limbic meaning the emotional cortex. So when you think about this, hallucinations, delusions, stuff like that, hyperactivity of that pathway. So you're going to want to, since it's overactivity, you're going to want to inhibit those dopamine, those D2 receptors. And these negative and cognitive symptoms, which doesn't seem very intuitive because when you think of these cognitive or these mood type symptoms, you kind of think it has something to do with the emotional and limbic system, but in regards to this, these negative symptoms are mesocortical, which is more frontal lobe and stuff like that. So definitely keep these separate because we're going to use different drug targets for those, and we won't go through this. Y'all know this. They're not going to ask you about. I don't think they'll ask you about this and stuff, but if you do. Some problems do come about if you do give some sort of dopamine antagonist. Remember, dopamine does inhibit prolactin, so if you give a dopamine antagonist, you could see increased prolactin and galactorrhea. Okay, and then the nigrostriatal pathway is more for Parkinson's, so we'll look at that. There's a lecture on that as well. All right, kind of goes into it here. Right, and this is how they think the serotonin works, which will some of the atypical antipsychotics will work as well. So haloperidol is a big one, but these are all your classicals. Remember, these classicals come with a lot of consequences, a lot of side effects. So now, ideally, they use these atypicals. Also, these atypicals work on those negative symptoms. These classicals were primarily worried about those positive symptoms, the hallucinations and stuff. Okay. Right. And here's the classical pathway, right, like I mentioned. So you're blocking your dopamine 2 receptors, mesolimbic pathway, those positive symptoms. That's what we're affecting. The classicals, that's really all they were worried about. Now, when they got to the atypical antipsychotics, they started addressing some of those negative symptoms, those symptoms that are mesocortical, and they were able to address those. And we'll get into some of these side effects. I don't think they really use that too much anymore, but right, atypicals, right? So by blocking serotonin, and again, you guys know by now, I try to make sense of these things in my head so it fits together, and it's very complicated for me to think that blocking serotonin helps with mood symptoms. You think you want to increase serotonin. Why are we even in the frontal lobe? I don't really know, to be honest with you guys. I don't know if the science even really knows. But for whatever reason, for these negative symptoms, mesocortical symptoms, we're giving a serotonin blockade. I think I did ask at one point about it, and they said something about blocking the serotonin in the frontal lobe helps to regulate the norepinephrine and dopamine in the frontal lobe. It kind of has this hierarchy type thing, but it sounded like a lot of jargon to me. But anyway, the point is, for these atypicals, for those negative symptoms, for those mesolimbic symptoms, we're going to be giving a dopamine 2 antagonist, right? And for these, those were for the, let me say it again. For the positive symptoms are mesolimbic, that's our hallucinations and stuff. We're going to be giving a dopamine 2 antagonist. For the negative symptoms, which are coming mesocortical, we're going to give this serotonin antagonist. Okay, and these are where these atypicals have this added effect. All right, now the problem here, right, you're going to get extrapyramidal side effects, but so with some of those, especially some of the more classical or the typical antipsychotics, you're worried about those extrapyramidal side effects. By blocking dopamine, you're really affecting that circuitry there, so you can get these like tardive dyskinesia where their jaw moves like that. You get dystonic reactions where they get kind of like locked in a position. I forget, there's a specific name for torticollosis or something like that, where their neck gets locked. But those are more for those typical drugs. All right, it does have this anti-emetic effect for nausea, but let's see. Right, so these specifically, again, those classical, those typical drugs, this dopamine antagonistic effect, these high potency conventional antipsychotics, specifically the haloperidol, that's a big one that's going to use it. So the mainstream approach now is to use the atypicals. But if you're going to have to use a typical, you could start with these low potency ones, okay? Chlorpromazine or thyroidazine instead of haloperidol or flufenazine, okay? Because these are very potent. All right, and when we look at these extrapyramidal effects, you're almost inducing Parkinson's disease in a sense, right? Because Parkinson's has to do with low dopamine. Well, here we're blocking dopamine receptors, so you're going to get this extrapyramidal effects. It's a complicated circuitry with dopamine 1 and dopamine 2. If y'all remember that basal ganglia pathway they did back in the day. So those Parkinsonian effects, dystonia, akathisias, those movement problems, tardive dyskinesia. The problem with tardive dyskinesia is that once it develops, it is irreversible. So it's kind of, if you see me, I kind of have like this jaw movement, sort of like that. That's involuntary, but that happens after you've been on pretty much these high potency medications for like 5 years plus. But even if you discontinue the medication, this does not go away. So that's why they really try to use more of the atypical antipsychotics these days. Okay, when we talk about Parkinson's disease, we'll talk about using these antimuscarinic drugs as well with it. Such as benztropine. And the way I kind of think about it is, if you were looking at a seesaw and you had less dopamine, you're getting too much of this acetylcholine effect. So that's leading to an imbalance. So by giving antimuscarinic, you're kind of evening out the seesaw, right? So you get equal amounts of dopamine and acetylcholine, and that's going to help you to alleviate some of these Parkinsonian symptoms. Okay, levodopa obviously is not going to want to be used in people with schizophrenia and whatnot, because by increasing dopamine, you're increasing the chance of positive symptoms with mesolimbic. All right, benztropine is the classic antimuscarinic that you can give for this dystonia. And some of these other ones, akathisias, clonazepam, propranolol. So you can give a benzo, or you can give some sort of a non-selective beta blocker with these sort of movement problems. All right, again, TD, irreversible potentially, so you have to be careful with this. But I believe you're going to get a lot more symptoms before this really develops. So ideally, even if you're using one of those really hardcore drugs, you would take them off before this develops. Okay, so it takes a long time. It's not like you just put the patient on it and it starts and then they can't ever get rid of it. It happens after about 5 years of treatment, if not more. Okay, and yeah, discontinuation is going to be the big one there. All right, yep, here's your risk factors. So again, I have these highlighted. Y'all know I post my notes, so everything is in my drive with my highlighted stuff. So big thing here, these are the big ones that are going to give you these extrapyramidal effects. So use these last resort. Yes, big one, right? So neuroleptic malignant syndrome. Dantrolene is a muscle relaxant. That's primarily what you're going to want to give if they get into this. So NMS, you're going to get this rigidity, hyperthermia, autonomic instability, stuff like that. And then in the labs, myoglobinemia, you would expect that if the tonic contractions, the muscle's going to break down. And anytime you get myoglobinemia, you can get rhabdomyolysis that could lead to nephrotoxicity. Okay, so ideally you can give dantrolene for that. All right, with autonomics, again, antimuscarinic effects are beneficial, so you can try to give like benztropine for that. Caroline, I think your mic's on. If you wouldn't mind turning it off. Okay. So yeah, thank you. Okay, so clozapine, the big one, they don't use this too much anymore. Agranulocytosis is a big deal, right? You need granulocytes. So if you get regular blood counts regularly to make sure you're in the therapeutic window, so you have to be careful with that. I don't remember them talking about any of this sort of stuff. So right, we mentioned by blocking dopamine, you get increased prolactin secretion, because dopamine is going to work on the anterior pituitary to inhibit prolactin. Some of these other ones, I don't know that really came up. You can see here, weight gain's a big one. Nobody wants that, but so that may be a reason that someone gets off of this and ends up on one of these one of the classicals or the typicals. If somebody has diabetes, you have to watch that as well for both the glucose abnormalities and the hyperlipidemia. Again, these get really busy for me. I don't know that if you're a chart person, go for it. All right. Then it goes into the indications. We kind of talked about these already. It's why do they use clozapine? It's something. Is it safe for pregnant women? Am I making that up? Okay, that's what it was. Yeah, right. So they don't use this unless there's some pregnancy. Yeah, that's what it was that came up. Okay. Yes. Yeah, I guess that makes sense. I mean, if there's nothing else you could use, you kind of resort to that. But they would have to get regular blood work, probably weekly or bi-weekly, to make sure they stay in the therapeutic window. Yeah, but if they do start talking about a pregnant woman that has schizophrenia, and they need to take her off of whatever medications she's on, you would want to go with clozapine. But yeah, you're right. All right, good. Let's see. I'll say this again. I know some people just joined in. I did find pleasantly surprised that this exam was pretty fair, especially in regards to the drugs. Like, I am skipping over some of the small details. I know some of the IMCQs were tough and stuff, but I did walk out of this exam like they could have really made it bad, and they did. So. That does not mean it won't be bad for you guys. I know you'll have different tests than us, but I could say that it was pretty straightforward in regards to the drugs, especially like when we get to the anti-epileptics. We'll talk about the side effects profile. That's what they like there. Tomorrow we'll go through the antibiotics, and I'll point out some of the important things there as well. All right, now back on our roadmap, do some pathology. And so fortunately, a lot of this is reviewed for you guys, right? Cerebral edema, whether it's vasogenic, if you have a problem with the vessels in the brain, extracellular problems, meningitis, encephalitis, all these kind of things are different from cytotoxic when we look at some of the neuronal or glial issues that you can see there. So this is kind of just a broad overview. Hydrocephalus, you just need to know the big differences that come in there. If it's in a child, typically congenital problems or some sort of acquired defect that can happen. Right, and this is the big one here. Non-communicating, which means you have some sort of obstruction, right? This is specifically the places, the aqueduct between the third and fourth ventricles there. That's a little pinch point that you can get there. So of course anything before that blockage is going to get dilated, right? And that's what leads to the hydrocephalus. Understanding which ones cause increased intracranial pressure is going to be a big one. They might not tell you they have eye pain and their eyes are bulging out. They might just tell you the patient feels nauseated and they have headaches. A lot of times that could be indicative of some sort of underlying increased intracranial pressure, okay? Especially the nausea. That's a big one that seems kind of vague, but you need to watch out for that. Communicating. A lot of the UWorld questions I'm coming across have to do with meningitis. So, of course, any sort of scarring due to the meningitis can lead to poor absorption. Remember the arachnoid villi? They pull the CSF, deposit it back into the venous system so it can be recycled. Okay, so you could get poor absorption. That's more common than something like overproduction from some sort of, choroid plexus tumor. So when you think of communicating, just think of this poor absorption. The arachnoid villi, scarring, tumor, stuff like that can be a problem. So of course here, because it is communicating, the whole ventricular system can be affected, right? And then we talk about ex vacuole, infarction, neurodegenerative disorders. Sometimes it can be age-related, but can somebody, that's not definitive. I think I asked one of the teachers about it. It doesn't necessarily have to be, but you do see that in age-related problems. So the point here being that the main thing you need to know here is it's loss of brain volume. But if you see what I wrote here, this is very definitive. There's no gait problems. There's no urinary incontinence. Okay? So they may not tell you the patient has increased intracranial pressure. Let me just come back to that because I'll show you what I'm talking about here. And this is the big one. So this is when you're talking about ex vacuole versus normal pressure hydrocephalus. Ex-vacu can lead to increased intracranial pressure, right? But they may not tell you that in the stem, but they may leave off the fact that there are, they may not tell you there are gait disturbances or urinary problems. In the stem of the question, for it to be normal pressure hydrocephalus, they pretty much have to tell you this, okay? So enlarged ventricular size is very similar to loss of brain volume when you look at it on an image, right? It, one versus the other, they kind of look very similar. So if we're talking about ex-vacuole, neurodegenerative problems could be age-related, loss of brain volume, but remember, you're not going to get this gait instability or urinary incontinence, okay? Because that's going to be definitive for normal pressure hydrocephalus, okay? And of course, if you lose brain volume, you have to compensate by having increased CSF. All right, wet, wacky, wobbly. Remember, if you see this, normal pressure hydrocephalus, enlarged ventricular size. Again, this tends to happen in older patients as well. All right, Pseudotumor Cerebri is just benign intracranial pressure. It's in women, obese women of childbearing age, yes. But again, it's very misleading. It's not due to a tumor. It's just this intracranial hypertension. Okay, so they could present with increased intracranial pressure, headache, papilledema, vision loss. Herniations. Okay, there should be a picture. Here's our picture. The big ones we're worried about when we have this tonsillar herniation is right here. You're worried about the brainstem, that first part of the midbrain, which has the area that controls your ventilation, that it controls your wake cycle and your consciousness. Okay, so if you compromise the brainstem, displacing through the foramen magnum, that's a huge problem because that's kind of your regulatory center. And then, of course, you can get, this is the transtentorial herniation. Okay, so in that case, when we talk about those epidural hematomas where you get this uncle herniation, that's when we're worried about the cranial nerve 3 problem. So actually, it says it here. So, right, when you get this transtentorial herniation, again, if you have like some sort of epidural hematoma, if you can see my cursor up here, it's going to push everything, it's going to push everything downward, okay? So they like to test on this, compression of the oculomotor nerve. So they'll say they had some sort of head injury, the eye is pointed down and out, right? So that could be indicative that there's an oculomotor nerve problem. But remember that the parasympathetics travel with the oculomotor nerve. So the eye will be down and out, the pupil will be blown, right? It'll be very dilated, mydriasis, and you can also get ptosis of the eye as well. Okay, so that could be indicative all of the oculomotor nerve. Because remember, once again, oculomotor nerve, the parasympathetics travel it. So if you pinch the oculomotor nerve, cranial nerve 3, you'll have compression of the parasympathetics, so you'll get unopposed sympathetic response. Okay, then you can also get here compression of the posterior cerebral artery, which controls that visual cortex. And if it's bad enough, you can end up with hemiparesis as well. Okay, these dirt hemorrhages. And then the last one they don't talk about too much, but this subfalcine herniation compresses the anterior cerebral artery. Okay, but the big one they like to talk about is this uncle herniation, this transtentorial one. All right, and then trauma to the brain, concussions, vascular injuries. Yeah, y'all know these by now. When those questions come up, everybody gets happy because we've seen it a million times. All right, concussions, contusions, pretty straightforward. Big thing about axonal injuries. I can't remember. I came across something in your world, but I can't remember off the top of my head. So these is damage to the white matter regions. Axonal swelling, maybe that was it. Okay, so versus some sort of Wallerian degeneration or stuff like that of the tracts, if you actually injure the axon, you're going to end up with axonal swelling and focal hemorrhages, okay? So any sort of swelling there could be some sort of axonal injury. Now, epidural, y'all know the story now. Some guy was playing sports, or whoever, played sports, got hit on the side of the head, was knocked out, got up, feels better. A little while later, he passes out. Okay, so rupture of the middle meningeal artery. It doesn't cross suture lines. It looks like a biconvex disc. right? It's epidural, so it's above the dura but beneath the periosteum. So you can see that there. Again, this is high pressure system because you're rupturing an artery, and if that's the case, it can lead to that uncal herniation. So then you'll get compression of the oculomotor nerve and the symptoms we just discussed. Subdural, you know the story here as well. Typically an older person may have a history of trauma a few weeks ago. These bridging veins are very slow bleeds, right? So you're going to get that moon-shaped lesion that you see there, that slow bleed. It can cross suture lines because it's subdural. It's between the dura and the arachnoid. Okay, so it takes a little bit longer. It's not as much of a medical emergency as the epidural. So you see those bridging veins. And what actually happens in older people as their brain atrophies, the distance of these bridging veins gets a little bit longer. So in that case, when their brain moves around, they're prone to rupture. Right? So venous bleed, subdural, epidural here, you can see between the periosteum and the dura. So y'all know that. Good stuff. All right. I think that's it. All right. Dr. Dasso's lecture, sedative and hypnotics. So back in the day, they used to use barbiturates, but as you can see here, there's a high risk of overdose here. They used to use, they still some, Casey, I think your mic may be still on. They used to use these for, and still do sometimes for anesthesia and stuff, but as you can see here, there's a very big risk of overdose problems here. You can see benzodiazepines are safer, they kind of taper off. Okay, so ideally you use benzodiazepines beforehand. The one thing they really like asking, because they both work on the GABA receptors, right? But benzodiazepines increase the frequency of the channel to be open, right? Whereas barbiturates increase the duration that the channel's open. Okay, so I'll reiterate that a few times, but that's a big differentiating factor. Okay, so chloride is the ion that goes through once the once the benzodiazepines bind. Right, and it does bind at both spots because there are some that we'll get to in a little bit that only bind one. All right, and you can see here how it works. GABA binding and the benzodiazepines. Okay, so the point being that benzos are basically used as an anxiolytic because they have this inhibitory neurotransmitter effect in the CNS and kind of slow everything down. They calm the system down. All right, and here it is. Benzodiazepines increase the frequency of the channel opening, right? So it opens more frequently, so more chloride can come through. Right, you can see that here. So more chloride can come through. Also has an anticonvulsant effect that you can use as well, but primarily anxiolytic, right? Antagonist, if someone comes in, again, whenever you see it where there's just one drug, yep, like cyproheptadine for serotonin as a serotonin antagonist, flumazenil for benzodiazepine overdose. Okay, so that's what they're going to give there. Definitely know that. Right, being lipophilic, it has a high volume of distribution, so it's going to be harder to get out of the body once it's distributed through. All right, this is important. Yeah, typically they use intermediate acting ones, right? So alloprazolam is Xanax. And again, I came across a UWorld question, and it was like, somebody had trouble sleeping. I was like, oh, just give her a long acting or whatever. Actually, because it's good to know these time frames, because if you actually if I knew the time frames at the time, you would say more of an intermediate acting would be better for sleep, because if you gave a long acting, they could be groggy the next day. So giving one of the lorazepam is a good one for sleep, or induction of sleep if need be. And they also have short acting ones as well. I think midazolam falls into the short acting category too. and clonazepam falls into the intermediate acting. Okay, so just maybe knowing these, just in case they ask you something. But again, if it's talking about sleep, trouble sleeping, insomnia, intermediate acting. Again, because if you give a long acting, they're still going to feel tired the next day. All right, kind of goes into how it works. Yeah, Dr. Dasso made a big deal about talking about all these things. So, there was one. What were he talked about like two that didn't. Yeah, these are the ones that skipped phase 1. Okay, yeah, probably good to know that. Maybe, I don't know, kind of low yield, but yeah, he did put a bunch of slides up here, so I say that's fair game. Diazepam, Valium can use for muscle spasms as a muscle relaxant as well. Right, and remember, status epilepticus, if they come in, seizure more than 5 minutes, or intractable seizures, you can give one of these, midazolam, lorazepam, diazepam here. For status epilepticus, I believe it's the first attempt at that's stopping those seizures in status epilepticus. Then you move to some more intense anti-epileptics. Yeah, I don't know if that really comes up. Diazepam, yeah, you should know that. Yeah, you can give a benzodiazepine for withdrawal. Yeah, so if they get into DTs, diazepam is a good long-acting drug to help with that. So yeah, again, and then they go into the sleep problems here. Yeah, a little bit low yield for that. Once again, flumazenil is definitely going to be super important because benzodiazepine overdose is super common. All right, then again, barbiturates, not typically used so much anymore just because they're high risk of going into a coma and dying from these because the toxicity there. Now, here's a big one where the benzodiazepines increase the frequency of the channels opening. The barbiturates will increase the duration. Okay, so they're open for longer periods of time. The chloride can come into the GABA channel because it's the duration. Okay, so it's a big differential there. And you can see here also can block glutamate and sodium channels. Yeah, so they can induce full surgical anesthesia at higher doses, which is primarily what they're used for now, opposed to for anxiety. Problem here, yes, with high doses, respiratory depression, big problem that could lead to death. I don't know that they really talk about it in regards to the CYPs, at least on the test. Thiopentol, phenobarbital. Y'all have heard of phenobarbital, tonic-clonic seizures. Yes, second line, I believe, for status epilepticus, safe in pregnancy here as well. Right. Now, the non-benzodiazepines only use one of the benzodiazepine receptor, primarily used for sleep. Zolpidem is Ambien, right? So you only use this benzodiazepine 1 receptor, so that's what they're called non-benzodiazepine receptor agonists, right? So you can use them as primarily as a hypnotic. So all the Z's, right? And this is just a precursor, right? So typically when they put an ES in front of the drug, it's just a longer acting precursor to it. Let's see. All right, so this is a very interesting one. It works on serotonin. It's an anxiolytic, okay, but it takes a while to kick in. Okay, so it has very unique properties. I would say definitely know this one. So you can give it for anxiety, but you need to tell the patient it takes a couple of weeks to kick in. So if, for instance, if you're worried about some sort of drug abuse and you don't want to prescribe benzodiazepines, you can give buspirone, and it has less of abuse potential, right? Because it takes a couple of weeks. But it's very unique in that it works on serotonin receptors, but it's only primarily effect is this anxiolytic, okay, not really for depression. All right. Melatonin, this one's easy because it looks like it says melatonin right there, Remlaton, right? So that'll help you with sleep. And then some of these other ones, I don't know if they'll really ask you about this stuff. Propranolol, yeah, that's fair. Performance anxiety, remember that's a non-selective beta antagonist. Clonidine, that is a alpha 2 antagonist, so it's got that weird alpha 2 effect, so it can actually help. It actually is used for blood pressure. So yeah, and it blocks the alpha 2s. Maybe it upregulates. Is it a does anybody know if it's an alpha 2 agonist or antagonist? Y'all could double check me later. I think what it is an alpha 2 agonist, because alpha 2 is an inhibitory. So because it works on blood pressure, I think clonidine. It's agonist. Okay, so remember alpha 2 is an inhibitor GI. So by giving an antagonist there, it can help with your blood pressure. I think the big thing there is you get really bad rebound hypertension if you could take the patient off too soon. But in regards to this, it can help with anxiety too. Again, if you're upregulating the alpha 2 receptors and it has an inhibitory effect, that would kind of make sense that it would help with anxiety. All right, diphenhydramine or Benadryl or antihistamine, sure, you can take that over the counter, stuff like that. All right. All right, drugs for anxiety, we kind of talked about these already, right? Remember, unless it's really short-acting anxiety like panic attacks, you want to just go ahead and give an SSRI. When in doubt, give an SSRI, right? Only time you really want to stay away from that is if they have some sort of bipolar disorder or history of bipolar or manic episodes, okay? Yeah. First line, we kind of talked about all this already. Buspirone, remember that's that weird one. Takes a couple weeks, it's just for anxiety. Benzodiazepines, right? Again, look, social anxiety disorder, right? SSRIs, anything long acting, use those SSRIs. Obsessive compulsive disorder, you can use SSRIs and even a TCA. Yeah, but if it's all there in the question stem, just go with the SSRI. PTSD, even so here, you're going to give an SSRI as well. Performance anxiety, that's when you can give those non-selective beta blockers, okay? All right, vascular problems. See, of course you know by now, ischemic stroke versus hemorrhagic stroke. If you have some sort of thrombosis or embolism, can lead to ischemic strokes. You can see that here versus hemorrhagic stroke. If you have some sort of aneurysm and sort of rupture, that can happen there. So they look very different on MRIs. Remember, a dark spot usually typically means some sort of area of ischemia, and if it's white, it's lit up, that's typically blood. Okay, so global versus focal, it kind of depends on the situation. If there's some sort of ischemia or hypoxia or some sort of bruit in the carotid, or something comes up and you have middle cerebral artery occlusion, you could get like global cerebral ischemia problem there. And focal would be more of a smaller embolus, maybe circle of Willis, some area there, even though that area does have a lot of collateral blood supply. Okay, so knowing that. Watershed areas, right? Remember that those are the areas that typically get the least amount of blood. So if you're gonna get some sort of ischemia, maybe the patient went into shock, so they're very hypotensive, these are the sort of areas that are gonna lose blood supply first, that are worrisome areas. Right. Remember, a lot of the problems, whenever a patient, and this comes up a lot in UWorld too, if atrial fibrillation is a huge problem when it comes to clots, because when the fibrillating is kind of shaking like that, it's kind of like, the blood is static, so you can form a clot there, pump it straight into the systemic circulation. go straight to the brain or can go anywhere really. But so you have to watch out for that. So these mural thrombosis, mural means wall, so stuff that forms on the wall of the atrium or even the ventricle. You have to watch out for there. But AFib is the big one here that they talk about, predisposing factors. So this needs to be addressed. So this doesn't happen. Ideally, the patient's on some sort of anti-clotting agent. All right, and then you can obviously form some sort of thrombosis or some sort of small clot there. Lacunar infarcts, that's a smaller area that you can get. Then you can see there, liquefactive necrosis is one of those unique characteristics of the brain. That's how that happens if you have some sort of blockage or some sort of stroke. All right, very importantly, first 24 hours, the nucleus shrinks, you get breakdown of the cell, breakdown of the nucleus, and then astrocytes are kind of those reparative elements. What do they call Microglia? Is that it? Microglia? Yeah, they're going to come in. They're like the macrophages of the brain. They're going to eat up the damage, and then the astrocytes basically use those foot processes. They're going to form. They're going to form the wall. They're going to basically go through gliosis, and which is basically fibrosis of the brain, right? So the astrocytes are going to wall off the area, and you're going to get some fibrosis or gliosis there. And then 24 to 2 weeks, you get necrosis, macrophages come in, and then this repair process, this gliosis, which again is fibrosis of the brain, is important there. So, but a lot of times they like to ask when the macrophages come in. So like a day to a week, some macrophages are a week. And you can see that here, reactive gliosis, residual problem. All right, intraparenchymal hemorrhages, those are in the parenchyma of the brain, so these are little small areas. Hyaline arteriolar sclerosis, that happens anywhere in the body when you have prolonged hypertension. So if you get a lot of that, you can get little hemorrhages, the lacunar infarcts. So let me go back. Lacunar areas kind of like feeds into the basal ganglia, right? So these little infarcts there, those can rupture because they're very fragile, especially when you're in a place of hypertension or a state of hypertension. Then non-hypertension problems, amyloid deposits. You see that with Alzheimer's and stuff like that. AV malformations. You're pumping a lot of high pressure blood into the venous system, so those can rupture as well. Even tumors. So right, intraparenchymal within the cells. Okay, subarachnoid hemorrhage. Right, remember the patient's going to come in. They're going to say this is the worst headache of my life. Berry aneurysms is a big one. So people with prolonged hypertension, they talk about patients with polycystic kidney disease. They're prone to this. The berry aneurysms. Subarachnoid hemorrhage is a big one. Medical emergency. You need to address it. Okay, and you can see this intraparenchymal that was like within the cells, and obviously this kind of got out of hand here. But small vessels, maybe this was a little lacunar vessel, and it just wasn't able to get to the hospital in time. And as I said, this hyaline arteriolar sclerosis just happens in the state of hypertension. Okay, so when the patient is hypertensive, this arterial sclerosis is kind of a responsive effect in the vessel to the prolonged hypertension. So you're worried about some of the smaller arteries that are going to undergo this. So basal ganglia, which are those lacunar areas, brainstem, stuff like that, even small microaneurysms. Some more definitions for you guys. So just keep in mind, stuff like these small vessels tend to be more fragile. They're going to be more prone to hypertensive issues. We kind of talked about these. All right, AVMs, which I don't even know that they really got into it, but the idea is that you're bypassing. It's a pathological bypass. So you have an arterial high system that has strong walls, and then you're attaching it pathologically to a venous system that does not have strong walls, right? So it's a very high pressure system that doesn't go through the capillaries to kind of slow down. It just goes straight from artery to vein. And in that sense, that's a very bad branch point where a lot of high pressure system gets into the venous system, and you can have a rupture, you can have a hemorrhage there. Okay, so you have to be careful with that. Yeah, look at the tangled network here. Okay. All right, and then subarachnoid, good trivia here. Where that branch port, where the anterior communicating artery comes across, that's pretty much where they happen. What sits right there, depending on the size of the aneurysm, you can affect the optic chiasm. If it's around the brainstem, you can even affect the oculomotor nerve. But when they talk about this, they usually talk about affecting that optic chiasm or the optic nerve, right? Okay. And you can see here, polycystic kidney disease, Ehlers-Danlos syndrome, problem with connective tissue. So if the connective tissue is in the media here is compromised, and like with PKD, you have hypertension. If it's unchecked, it's a bad situation. You can lead to this. Remember, they say just like cardiac arrest. It feels like an elephant sitting in your chest. These subarachnoid hemorrhages. The patient comes in and they say it's the worst headache of my life. Okay, and you can see that. Look at that aneurysm right there, and that's that branch point. You see the brainstem here, the circle of Willis. That's right at that branch point that we were talking about right here. Right, it's like overlaid. All right, you can see that here. Huge berry aneurysm. Thunderclap headache, or worst headache of my life. Okay, meningismus, neck stiffness, photophobia. If it's bad enough, it can compress on the meninges in that area, so it could lead to that. So yeah, so if there's any sort of signs of meningitis, neck stiffness, but there's no signs of fever or anything like that, and there, maybe you could lean towards this. Right, remember, if you expect a bleed in the brain, this is a good way to get malpractice suit. If you expect a bleed in the brain, don't do a lumbar puncture until you get a CT scan, okay? You need to make sure it's not actively bleeding, because if you do a lumbar puncture without it, you pull the brain stem right through the, because of the negative pressure, you could pull the brain stem through the brain through the skull. So you have to be careful with that, okay? Good. All right. Anti-epileptics. Now, these are kind of a pain. The side effect profiles are going to be what makes them unique. Okay, so that's a lot of the questions you guys are going to come up with. Sadly, over the last few years, they've renamed some of these, so you're going to get both names, generalized, and I think they go into it. These partial seizures versus generalized, and then now they have new names. So anyway, partial seizures, no loss of consciousness. Okay, simple partial, no loss of consciousness. Okay, complex means you lost consciousness. You can get these motor movements as well that happen. Partial means it's coming from a specific foci, right? Whereas global means it's encompassing the whole brain, right? So if you have a partial, it could stay partial, or it could actually activate maybe the thalamus, and that could kind of have this prolific effect to make this generalized. Okay, so you started with a partial right here. Then you had a secondary generalized, so it activated this, and then from that point you had a tonic-clonic seizure, which kind of hyperactivates both sides of the brain. Okay, and you would expect a loss of consciousness there. Okay, then generalized seizures really don't have a specific foci. Anything could go wrong from that point because you're really bihemispheric here. Okay. Absent seizures, important. They talk about a kid sits in class, he's not doing well. Sometimes he stares off into space, or the parents will talk about him staring off into space, and then it just kind of comes to. Very characteristic is this. If they ever talk about a 3 Hertz spike in wave, they're talking about absent seizures. And we'll get into the drugs. Ethosuximide is this specific drug you want to use for this, but we'll get into that in a little bit. All right. this should make sense. Glutamate and GABA in the brain are primarily counteracting each other, so you have some sort of imbalance there that can lead to these seizures. Interesting, people with these really complex, whenever you have time after the exam, some people have hundreds of seizures a day, and it's so complicated. What they ended up doing is they split the corpus callosum in half, so the brain to help to alleviate these seizures. But both sides of the brain don't talk to each other anymore, so it's very interesting. Go look it up on YouTube. Like one of the hands will go to scratch the face, and the other hand will like move it away. Like the brain doesn't talk. It's quite interesting. But they've been able to utilize that to stop these intractable seizures. But it's pretty cool looking, pretty crazy looking. All right, talk about that. All right, let's get into the drugs. Now, knowing where these drugs work primarily is going to be a big one here. So when we talk about these tonic-clonic seizures, these are going to be big ones here, these two. I did write in my notes where else they work, but for the most part, you just kind of need to know what that primary one, like this, exactly. So the sodium, so it's blocking this glutamate, the sodium here from entering, so you don't get this signal propagation. So these are the big ones that are used here for this. These are your the drugs you're going to use for tonic-clonic seizures. So that's going to be first line for that. Let's see. Now, when we talk about these T-type calcium channels, these are what you're going to use for those absent seizures. Ethosuximide, ideally. You can use valproate as well. So remember that 3 Hz spike, those absent seizures. This is a great testable drug because it's the only time you'd really want to use that. Okay, and you can see that here, T-type calcium channels. Whereas let me go back. This is going to stop propagation. Okay, but this is actually when we look at these, this is actually at the terminus, so you don't get calcium influx here, and so you won't get propagation from the nerve terminal. Whereas again here, this is coming in, on the nerve fiber, so you're not going to get propagation down here. So it's a big difference here when we look at this. All right, then you have some that affect GABA pre and postsynaptically. We know that at the postsynaptic ones are going to be the ones we talked about already that affect the GABA receptor opening. Benzodiazepines have an increased frequency. Barbiturates have an increased duration of opening of the GABA channel that allows chloride in. Okay, topiramate as well can be used. All right, now we see here we're postsynaptic. We're going to bring the chloride in. Now, why would we want to bring the chloride in opposed to block it? Because GABA is inhibitory. Okay, so this is an inhibitory complex. We're trying to shut down or dampen the effect of the seizures. Okay, and then some of the presynaptic ones that can be used. I don't know if these were highly tested. I don't know how often they're actually used in practice, but they're there as well. And you can see that here, they're presynaptic. They will help to propagate, not propagate, but they will help to release these synaptic vesicles with GABA. The more GABA you have, the more inhibitory input you can have to helpfully stop the seizures. Okay, and then glutamate should work opposite of these GABA, right? Because glutamate has a positive impulse, whereas GABA has a negative impulse. So presynaptically, you're going to want to stop the GABA from coming in, right? So it's going to block sodium channels. You're going to stop the glutamate from coming in. So you're going to block sodium channels postsynaptically at the glutamate receptor to stop that positive impulse, okay, and then propagation down the nerve. Gabapentin is primarily used for neuropathic pain, but you can help to dampen this glutamate response here by giving gabapentin, so presynaptic voltage-gated calcium channels can be blocked, okay? And you can see that here. So if you block these calcium channels presynaptically, you're not going to release glutamate, so you won't get that positive impulse, so you can help with pain symptoms, or even here with seizures. But I think for the most part, gabapentin is used for neuropathic pain. This one, I'm not going to try. All right, so it's very unique in how it works. The synaptic vesicles, SV2A, I think there's a picture. Yeah, so it blocks these synaptic vesicles. So here's another one, single drug that has its own little category. So I would say that's definitely testable. All right, so again, generalized tonic-clonic seizures, you want to use these drugs that are going to stop that sodium propagation, the sodium channel, so those primarily all fall into that category, okay? Major ones, opposed to even this one, knowing these is probably more beneficial to you. Carbamazepine, all these right here. So yes, these are going to be the ones, and they pretty much fall in the same category. Generalized seizures, remember, absent seizures, ethosuximide. First line, if there are some signs of tonic-clonic seizures, you can go ahead and use valproate. Right, and even if it's atypical absent seizures. So if you have an absent seizures, plus you also have some sort of like motor movements and stuff, you may classify that as atypical. So you can use valproate. Myoclonic, like twitching, you get clonic contractions. You can give these as well. Unfortunately, I don't have much for you there. This is just a lot of memorization. Atonic, right? Seizures as well. Seem to be refractory, so you can give these. Febrile convulsions have to last long, or if they last less than 15 minutes, it's supportive. Anything over that, you can give diazepam to help with benzodiazepine, okay, to help with that. And then we talked about status epilepticus here. I think, yeah, this is it. So this is good to know. If the procedure's more than 5 minutes or they're continuously going, you can start out with a benzodiazepine. If that's not working, you can give something a little bit stronger, give valproate. And if it's continuing, you can give something like phenobarbital or propofol or something like that. Okay, so knowing that's going to be important. Drug-induced seizures, yeah, I'm not sure how high yield that is. All right, now this is going to be what's important. You know these now. I remember PPCR for these, the ones that induce cytochrome P450. So of these, PPC all induce cytochrome P450, and they all are anti-epileptic drugs. The R is for rifampin, which is used for TB. So that'll also induce induce cytochrome P450. Okay, so definitely know these. This can affect drugs, particularly stuff like warfarin. So you have to be aware of this. Definitely testable. Valproate, it's a teratogen. It affects folic acid production, so you can end up with neural tube defects. Hepatotoxicity is the big one here as well, so you need to be aware of that. Phenytoin, gingival hyperplasia is one of those weird things that at least to my knowledge, I can't think of anything else that causes that, so that's specific there. Hirsutism or hair growth, even Stevens-Johnson syndrome can happen there. Importantly, it is one of the things that is zero-order kinetics. Remember, APE is the mnemonic for that. Alcohol, phenytoin, ethanol, phenytoin. What's the other one? High-dose aspirin, thank you. Right, so those are zero-order kinetics. They are eliminated by dosage, not by percentages like the first order kinetics, which means this is a very high risk of overdose there. Okay, carbamazepine, aplastic anemia, agranulocytosis, big deal. Also Stevens-Johnson syndrome, which is basically a very serious, skin reaction, medical emergency skin reaction. They may have a picture of it coming up. If not, I think there's one in first aid. But you have to be aware of this. You have to get regular blood monitoring for this there. Here we go. Yeah, so this is the big ones you want to remember for Stevens-Johnson syndrome: phenytoin, lamotrigine, and carbamazepine. Okay. And then, yes, I think my understanding is TEN is just a worse complication of Stevens-Johnson syndrome, but you pretty much go through the same process. Lamotrigine, carbamazepine, big ones, and then phenytoin was the other one. All right, phenobarbital, again, it wasn't listed, so there's a lower risk of Stevens-Johnson syndrome there, but phenobarbital being a barbiturate, sedation, drowsiness. You could be careful with overdose, respiratory depression. Remember, because it's a barbiturate. Yeah, I don't think that one came up. No. And I just say no because I don't remember it coming up on the exam or any questions, but that doesn't mean it's not going to come up. But yeah, like I said, for the exam, they went pretty straightforward. All right. Pregnancy, remember, valproate, folic acid problems. Got to get the mom off of that. Don't want any neural tube defects. Hemorrhagic disease, increased degradation. Well, they give newborns vitamin K supplementation when they're born, but it says here even in the final month of pregnancy, you want to give it as well. Okay, so you have to be careful for bleeding. And yeah, I guess I would say this is fair game. Knowing which ones are which. I'd say low yield, but I'd take a look at that for sure. No. I mean, theoretically, I don't think they're going to ask you about any of this. Yeah. All right, what time do we start? Y'all want to take a little break? It's up to you guys. Okay, well, let's see what else we got. We'll keep going for a little while. How about that then? Y'all let me know. Okay, so neurodegenerative disorders, y'all have learned about these a bunch, but knowing the pathology behind it, what actually builds up in these is going to be important, because now that's what they're going to test you on. Alzheimer's, right, well, let's see. Okay, so primarily problems with memory, right? And we say memory first because there are some things that deal with memory that also have personality changes. So with Alzheimer's, the big thing here is we're going to be talking about memory loss, significant memory loss with age. It's progressive, it's irreversible. It's confirmed technically only during autopsy, so it is a symptomatic diagnosis while the patient is alive. These are the big things, these amyloid beta plaques that form, these amyloid deposits, tau proteins are formed as well. These are going to be extracellular, which is important. I'm sorry, the amyloid beta plaques are going to be extracellular. Now the tau proteins actually develop into these neurofibrillary tangles. Okay, they aggregate, so you can actually find these intracellularly there. So if they talk about this, if they talk about a patient that has memory loss, older patient, you look for these amyloid deposits, these A beta deposits, and these tau proteins, these neurofibrillary tangles that form extracellularly. Okay, this kind of goes into the process. I don't know that was super testable there, but right. So yeah, and even being able to identify these as pictures, right? So you can see these little amyloid deposits extracellularly, and these tau proteins, these neurofibrillary tangles. At least for STAP, like I've seen questions that have imaging like this for UWorld, so I think that's fair. Again, you can see these little tangles here, these inside the cells, these tau proteins that develop. Okay. Oh, sorry, let me go back. Yes, early onset, you get these presenilin genes that form. I think that's fair game versus these ApoE that tends to be late onset. So before 65 years of age, remember, that's a very important point, Down syndrome, because it's on chromosome 21, these early onset, these precursor proteins, patients with Down syndrome have a very high risk of developing Alzheimer's at an early age, okay? Let's see. You can see this ventricular enlargement, okay? So hydrocephalus, that's ex-vacuole, because you get neuronal loss, okay? Gliosis as well. And again, just burn it into your brain. neurofibrillary tangles, and these plaques develop as well. Okay. Now, when you talk about frontotemporal lobe degeneration, remember the frontal lobe is going to control it's your inhibitory complex for your limbic system, right? So it kind of tells your body this is inappropriate, right? Like if your limbic system is all haywire thinking about emotionally, your frontal lobe is kind of like what calms it down, right? Which says like this is more socially acceptable, right? So if you get frontotemporal lobe dementia, specifically the frontal part, you are going to worry about behavior changes, okay? So progressive behavior changes or language problems, but the memory problems come later. Okay, so you have to be very careful when you look at these questions. If the patient or the patient's family comes in and they talk about behavioral problems and a little bit of memory problem, you want to lean towards this. Whereas if it's just memory, they're forgetting their keys in the refrigerator and stuff like that, then it may be Alzheimer's. Okay, so remember, if you remember, the frontal lobe kind of controls your ability to inhibit, your mood symptoms. Then you can keep this in mind with the behavioral changes. Now, you also see buildup of tau, but they're specifically related to frontotemporal lobe dementia tau, or or TDP. Okay, so more specific for that. Okay, now Parkinson's. Again, you've learned this a billion times. Loss of dopaminergic neurons from the substantia nigra. So you know that it leads to this clinical features: tremor, rigidity, Brady or akathisia. Now, what's important pathologically is buildup of this alpha-synuclein gene. Okay, so that's what you're going to see there, build up in the substantia nigra. And you can see that here. This is the substantia nigra. These are those neurons. It's depigmented at this point, so you lost those neurons. Those neurons are actually what cause that reaction that actually makes dopamine, okay? That tyrosine reaction where it goes all the way through and you get L-dopa, L-dopa, that whole thing, that happens there. So if you don't have those neurons, you can actually, you can't make dopamine, so you get these movement problems. Now, Lewy body dementia, if the dementia develops within a year of the motor symptoms, okay, that's very important. I'll say it again. Lewy body dementia presents very similarly pathologically. So if the dementia develops within a year of the Parkinson motor symptoms, you want to classify it as Lewy body dementia, okay? And it says here cortical involvement. Okay, so yeah. So you get dementia plus movement problems. So a lot of these have a little bit of overlap. You need to look at the time frames with them, sort of like the psych disorders. All right, now Huntington's disease, remember that's autosomal dominant. It has those, the process of anticipation where you get those trinucleotide repeats. The more you have, the sooner the onset. Okay, so the striatum, which is made up of the caudate and putamen, particularly caudate degeneration is what they talk about. Remember, Huntington's is bilateral, so you get bilateral caudate degeneration, whereas hemibolismus is unilateral. But again, you get this polyglutamine, CAG codes for glutamine, so you get polyglutamine trinucleotide repeats. Okay, so this is what you would expect. Don't forget that these patients tend to have mood problems. Now, I don't think it's necessarily. My understanding, it's not necessarily just because they have Huntington's they feel they have a decreased mood. I think there's actually pathologically there's something that has to do with it that affects because there's a higher than average risk or incidence of depression and stuff with these patients. So mood symptoms does come up as one of these things. Cognitive changes, yes. All right, so again, this kind of goes into the process of anticipation. The more repeats you have, the earlier the onset. If your dad got it at 50, you should anticipate it getting before then because you're going to have more repeats than your dad did. All right, goes into these different motor symptoms and cognitive symptoms as well that can happen, but this is all pretty much review for you guys. Marked atrophy of the caudate, right? So you should be able to identify that. Intranuclear adhesions, it's called the Huntingtin protein, so that makes it easy. yes, ubiquitinated Huntington protein, and there's those little inclusions that form. Okay, atrophy of the striatum and ventricular dilation. All right. Good, and then ALS, remember ALS is a purely motor problem. You can get upper motor neuron and lower motor neuron problems, okay? So a couple of things pathologically that come up is superoxide dismutase gene. They talk about that, you need to think ALS, that comes up. But again, when you're looking at the symptoms, I'll give you a bunch of them. Just make sure there are no sensory symptoms, okay? If it's sensory, it can't be this. It's only motor, lower and upper motor, okay? You see this? Remember, upper and lower motor are pretty much opposites. Upper is more of a spastic paralysis. Lowers have more of a flaccid paralysis. The only one that kind of trips people up is the fasciculations. That's which is kind of like twitching. That falls under lower motor neurons, okay? But with ALS, you'll see both of these. Okay. All right. Yeah, and these the anterior. Remember, the anterior side controls your motor movements of the spinal cord. Anterior horn cell neurons. Right. That's where the motor system develops. It's kind of that junction point between the upper and lower motor neuron. So that's the area that should make sense where you get a lot of problems with these myelinated fibers there. Okay. All right, let's go ahead and take just a few minute break. We're at an hour and a half now, so we'll take a few minute break and then we'll go from there. Sound good? Good. Good. All right, quick one. All right, patient comes in, history of depression, comes in with constipation, urinary urgency, dilation of the pupils, flushing, dryness of the skin. What are you worried about? What kind of overdose are you worried about?
So TCA or monoamine oxidase inhibitor.
Okay, and if you had to lean towards one, what would you think? I would say probably, yeah, I would probably say
TCA?
Yeah, just because of the anticholinergic effects. Yeah, you would lean towards that. And then what are they at risk for in the hospital? What are they at risk for, and what do you want to give for it?
So they're at risk for cardiac toxicity, so you would give bicarb for that.
Yeah, exactly. So that's a good one. That's a good test question. It comes up in UWorld, so I thought, I don't know why, considering that. Yeah,
can you repeat the question again? Sorry.
Yeah. So a patient comes in with urinary urgency, pupils are dilated, basically a bunch of anti-muscarinic effects.
Okay.
Yeah.
I missed that part.
yeah, right. So, and then you have the antihistaminic effects. They may feel sedated. Technically, they may be bradycardic at first, but you may actually get reflexive tachycardia because it has anti-alpha-1 effects, right? So alpha-1 will tense down on the vessels. So if you have anti-alpha-1, you'll get dilation of the vessels, so you'll get reflex tachycardia. Okay, so my point is that the TCAs have an anti-muscarinic effect. They have anti-alpha-1 adrenergic effect and antihistamine effect. Now, what they also have is that when the patient comes in, TCA overdose, you're worried about cardiac toxicity, okay? So what you want to give for that is classically sodium bicarb, and that'll help to eliminate the drug. So again, that's why they tend to prescribe SSRIs, they're safer, stuff like that, but TCAs is the one they like to talk about with drug overdose. Okay, let me share my screen and we'll get going. I did find a good picture I wanted to show y'all just in case they give you this. Right, so let's see. Right, I just wanted to point out for you guys, because they like to show, this is the caudate, right? So if there's caudate, you can see kind of this induration in this grayer area, right on the lateral side of the lateral ventricles, right? So that's, if you expect Huntington's, you get degeneration of this area. They may just give you the guy's symptoms, may just talk about anticipation, may talk about any of that. They may not tell you the actual disease. They may just point to a picture,
lines everywhere. Remember, it's the caudate, okay? So inevitably, you're gonna get enlarged lateral ventricles due to the atrophy of the caudate. I just wanted to show you that because there wasn't really a good picture, I thought, in the lecture. Okie dokie. Wait, did y'all saw that? Was I sharing my screen?
Yeah, it showed up.
Yeah.
Okay, sorry, okay, I think we're good now. All right, good. Let's see. Now, Parkinson's, again, we kind of touched on it. In regards to, remember, what are you looking for? That alpha-synuclein, right? That's the deposits you're going to looking for Parkinson's. Remember, if you can get mood disorders. Sorry, that was with, you can also get Lewy body dementia with that. So if the dementia happens within a year of the Parkinsonian symptoms, of the motor symptoms, you want to diagnose it as Lewy body dementia. They both have Lewy bodies. It's just you're trying to define it. So if the dementia happens within that first year, it's going to be Lewy body dementia. Okay, y'all all know this by now. This is called a resting tremor. That means the patient, if he's just sitting there, is rest. If you tell him to touch your finger, the tremor stops. Okay, it's very different from cerebellar tremor, which is called an intention tremor, where the patient's fine, you tell them to touch your finger, and then they start shaking. Okay, so that's called an intention tremor. That's usually due to a cerebellar problem. While we're talking about the cerebellum, and I'm going to go through it a little bit on my own with you guys, some of the tracks and stuff very briefly. But remember, cerebellar problems are ipsilateral. Okay. The left cerebellum controls the left side, right cerebellum controls the right side, whereas all of the motor symptoms to the cerebrum are crossed. Okay, so keep that in mind. But again, this Parkinson's is a resting tremor. When they start, it's hard for them to get going, but when they get going, the tremor stops. Cerebellar problems, they're good until they start doing something. It's an intention tremor. That's why they get the pass pointing and the diadococohesion, all that stuff. Okay, right, again, problem with this nigrostriatal pathway. That's the problem. So tyrosine, you know the pathway, phenylephrine, not phenylephrine, you know what I'm talking about. Yeah, so tyrosine gets broken down into L-DOPA, DOPA, norepinephrine, and epinephrine, right? So this actually happens in the substantia nigra. Right, and this is that rate-limiting enzyme, tyrosine hydroxylase, there. And you can see, and eventually you make dopamine. All right, so what I really want to get to is the drug, so we can, because this is all pretty much review for you guys. Yeah, you can see the substantia nigra has degenerated there, so you're getting loss of neurons in that area. Okay, here we go. Right, so first line's typically levodopa. It's basically a precursor to dopamine. You can give that. The problem is that it tends to be degraded in the peripheral nervous system before it can get to the CNS. So there's a way around that. You always give levodopa with carbidopa. Okay, but I guess we would talk about levodopa first. L-DOPA uses dopa decarboxylase to form dopamine. So this needs to happen. Dopamine will not cross the blood-brain barrier, so it is transported as L-DOPA or levodopa, okay? Carbidopa. Now, this is what is, it'll inhibit dopa decarboxylase in the peripheral nervous system, but conveniently it doesn't cross the blood-brain barrier. So what this does is it allows more L-DOPA to get into the CNS, then dopa decarboxylase can convert it to dopamine, then there is more exogenous dopamine that can be used for the patient, for these Parkinson's patient. They actually give it as a prescribed pill now. You don't really need to know that. All right, now there's some other ways. Yeah, you can see even still, right? Even still with it, only 10% gets to the brain, but that's much better than 1 to 3%. Okay, now you can also give these COMT inhibitors that they talk about. Yeah, I'll talk about it in a second. Okay, before that, vitamin B6 is a cofactor for dopa decarboxylase reaction. So vitamin B6, you want to be sure that the patient has that as well. I don't remember them talking about a lot of the side effects for this. It's basically dopamine. So as long as you can get it to the CNS. Okay, we're going to talk about the COMT stuff in a second. Let's get to these. Now, these are dopamine receptor agonists that they have. They have the ergot dopamines and non-ergot. So bromocriptine, you've heard of that before, D2 agonist. I believe, yeah, so they use the other kind, these two, more often. So these are non-ergots, pramipexole, ropilirone, well tolerated. They say to give it for younger patients. Less effective than levodopa for the motor symptoms. Okay, so first line still is levodopa, but if they're talking about something that will also increase that dopaminergic effect, these are dopamine agonists, okay? Right, receptor agonists. All right, you can get it in transdermal form. I don't remember, again, them asking a lot of these side effect profiles for these. That would be a huge problem, right? Somnolence. But again, they just, this is just used, it basically has the same effect as dopamine, as the L-Dopa. It's a receptor agonist. Again, we talked about this earlier, psychotic illness or psychiatric problem, particularly stuff like schizophrenia, you can't give the dopamine to these patients, okay? Because the whole point of treating schizophrenia is to decrease that dopamine in the mesolimbic system. So if you're giving them exogenous dopamine, that's a huge problem, okay? I don't remember them discussing this too much. Yeah, this was the big one that came up. So selegiline is a MAOI, so it's gonna help to inhibit the breakdown of dopamine. Okay, so if you want dopamine, L-Dopa to work for a longer period of time, you can give something like selegiline. Remember, those MAOIs have a lot of those side effect profiles, those tyramine profiles with the cheese reaction. Got to watch out for serotonin syndrome. Remember, anytime they talk about a patient that has flushing and diarrhea, the first thing I think of is some sort of serotonergic problem. Okay, those typically go together with that. All right, and then these are very important, tocopone and entacapone, right? These are COMT inhibitors, so these will prevent the breakdown of L-Dopa. Okay, so these COMT inhibitors, one of them, which one? Yes, okay, so entacapone does not cross the blood-brain barrier, so you can get more L-Dopa to get across, and then tocopone can cross, so it'll be in the CNS. So yeah, so knowing which ones go there, I think is important. But those are COMT inhibitors, so they will prevent the breakdown of dopamine. Okay, so remember that MAOI and COMT can break down dopamine. So in that regard, if you can block those, you can help. You can the medication can work longer in the patient. The L-Dopa can. All right. Yeah, I don't think they really asked about that. That's actually obviously a bad problem, but I guess first line you use entacapone. Yeah, preferred. Okay. Mantidine is this weird one. I think they figured it out by accident. Antagonist of the glutamate receptors, but it also has increased dopamine release and increased dopamine reuptake. So more dopamine is available for this patient. But it's one of those ones that was figured out by accident. Libido reticularis, you can see that here. That can happen with that. I know, guys, I know I'm basically reading off the slides for a lot of this stuff. I'm just trying to jog my memory of what was important or not. But unfortunately, there's not a lot of understanding that goes into these drugs. It's a lot of memorization. Okay, so what I did say earlier is that a lot of the Parkinsonian symptoms are due to a decrease in dopamine, right? So if you can kind of stabilize the effect of the dopamine and the acetylcholine, it's like a seesaw. So if you have decreased dopamine, if you can stabilize the dopamine and the acetylcholine, on the seesaw, it can kind of improve this tremor and rigidity, these effects of all of these, all of these Parkinsonian effects, right? So again, if you have too little dopamine or too much acetylcholine, if you give an antimuscarinic, you could decrease the acetylcholine. You can kind of stabilize the dopamine acetylcholine ratios, and by doing that, you can improve some of these effects. Okay, so it's just kind of a balancing act. This is very busy. Right. So again, first line, levo and carbidopa. Then you use those dopamine receptor agonists there. You can add a COMT or an MAOB inhibitor so that it levodopa can be there longer in circulation. And then again, these anticholinergics can be given to kind of stabilize the dopamine acetylcholine balance there. Okay. And from my understanding, this treatment, as with a lot of things, this treatment is patient by patient. You kind of have to titrate the amount of binge tropine and dopamine agonists to kind of, figure out what works for the patient. So it's no easy feat. All right. So again, this should be a lot of review for you guys too. Demyelinating diseases. So MS, and we have some of these other ones that these post-effects is ones that are a little less high yield. But remember, MS, you get these different CNS demyelinating patterns. They kind of wax and wane, separated in space and in time. So a lot of times the first symptom is difficulty seeing or diplopia, typically young females in their 30s. Come in with this, and it seems transient. The vision will be bad, then it'll go back to normal. Then the way when I look at these questions, when I see MS or I'm suspicious of it, it's usually because they give me a lot of symptoms that don't seem to correlate. There's some sensory problems in an arm, there's some motor problems in a leg, there's vision problems, just random stuff. When it comes up random like that, I tend to think this. You need to be systematic about it. Whereas ALS tends to be purely motor problems. When you're looking at this random pattern here, MS is usually the first differential. Okay, so they do talk about this. I don't know how high yield this is, but they do think there are some factors that go into it. Right. So loss of myelin is the big thing here. That's going to be a big one because that's the whole demyelinating process. Plaques, yeah, you can see this demyelinated area here. Okay. So multiple relapses and remissions. So that's what I meant by saying it waxes and wanes, it comes back and goes. Big thing here in red. Diagnostically, what you're looking for is oligoclonal bands in the CSF. Okay, if they say that, you're thinking of MS for sure. Now there are some post-infectious demyelination that you can see here. There's ADEM, right? So I don't think they really asked about this, AHEM, but I would at least look at this. You could see this after some sort of viral disease. What does that remind you of? Remember Guillain-Barré syndrome, even though that's a peripheral problem, that's usually post-GI viral infection a couple weeks later or whatnot, you get peripheral demyelination that tends to resolve within 2 to 3 weeks. That's Guillain-Barré. But this is encephalomyelitis, so that's in the brain. So again, same kind of idea. It's a post-viral disease that can happen there. Now, central pontine myelinolysis, big thing here is patient comes in with hyponatremia, low salt, and you try to give them salt too quickly, okay? So you try to correct the hyponatremia too quickly, and it is a damage to the oligodendrocytes, which will help to myelinate the nerves. So if that's the case, you can get problems there. They have found that you can find it extrapontine, but for now, just knowing that it typically happens in the pons, okay? So that's where you're worried about that. So yeah, and it gives you some of these. They might not say the patient's hyponatremic, But if you have a renal problem, obviously you're not reabsorbing sodium, vomiting, diarrhea, you lose it. SIADH is a big one because you're basically diluting all of your salt. You're just bringing back free water into the system. So if that's the case, you're very dilute. So just keep that in mind. You can see this if you try to correct too quickly for the salt deficiencies. Yes, always B12, thiamine, big testable problems. Patient comes in with macrocytic anemia, hypersegmented neutrophils. Your first thought is it's B12 or it's folate. Then you ask yourself, is there any sort of neurologic problem? Because that would say that it's definitively B12, not folate. So yeah, you can look for that. And also diagnostically for B12, if you find methylmalonic acid, that is diagnostic, right? Because that's the process. That's one of the two places B12 works. It also works in the homocysteine pathway. So that's one of the places. So if you get methylmalonic acid, definitively that's B12. So, and some other things can obviously cause problems here. Thiamine, remember, typically in alcoholics, they don't have a good diet, so they lose vitamins. Wernicke's encephalopathy tends to be confusion, ataxia, and intranuclear ophthalmoplegia, which is basically just double vision, okay, diplopia. Okay, so that you can actually have Wernicke's encephalopathy before you get the Korsakoff symptoms. Okay, so if you have these three, that defines Wernicke's. Okay, these three, this triad. But then if it gets worse, you can get Wernicke-Korsakoff, and Korsakoff has to do with the confabulations, where the patient seems to be making up stories that he believes are true, she believes are true, and but they're confabulations, they're completely made up. Okay, so there's a lot of science that goes into that, but we won't worry about that. Mammillary bodies, that's the big one. If you were to remember something very specific for Wernicke-Korsakoff, so this mammillary bodies are what gets hemorrhage and necrotic. Okay. Neurotoxic, alcohol, think cerebellar problems. So cerebellar degeneration can have that. So think, problems with proprioception, things like that. Okay, now, this is the big one. I would definitely take my time looking through these. These are very specific, and unfortunately, there was only a few ways to differentiate these, okay? And it's age is a big one, location, and the pathology that's behind it. Now, for now, knowing stuff like this tumor has psammoma bodies, right, is good. But I found studying for STEP that a lot of times they won't tell you there's psammoma bodies. They'll say, this patient comes in, which seems like there's a tumor, and there's calcifications there, right? So it's hit or miss. I'm not going to tell you to go have a definition for all of these little words, pseudopalisading and stuff like that. You may get away with it on the test. They may tell you straight up, but for long term, you're going to kind of need to know what the definition is, because they're not going to make it that easy. Okay, so big thing here: kids infratentorial tend to be cerebellar, adults supratentorial. It's a good way of differentiating it if they tell you the location, or better yet, if they tell you how old the patient is. You can kind of eliminate a lot, about half of them there. Glioblastoma is pretty common. Pilocytic astrocytoma is the kid version of it, but glioblastoma is the big one. Remember, it has this butterfly glioma, meaning it can actually cross the midline, cross the midline. So it kind of, we have it here. It is. So you can kind of see it here. Okay, so that'll be a glioblastoma. If they talk about it's crossing cerebral hemispheres, obviously supratentorial, that would imply that it's an adult. Okay, pseudopalisading necrosis. That's important. I've come across questions where they basically just give you this picture. Okay, what does that even mean? Okay, so you can see here, this is an area of necrosis, and you can see kind of these cells that this is called palisading, or this area of necrosis here, and you see these cells kind of surrounding it. That's what they define as pseudopalisading. Okay, so if you see that, or if they say the word pseudopalisading, that typically means that you are talking about a glioblastoma. So it's an area of necrotic tissue, like right here, and you get this palisading, or like these cells that kind of surround it, right? That kind of circle around it. This isn't the best picture. There are some, I don't know, you probably can see it better if you start searching on Google. Like they'll show like a little area necrosis and there's just cells kind of surrounding it, like trying to get close to it. So that's how I remember that. Now, oligodendrogliomas, remember, look at this. Why do they look white like that? Well, because remember the oligodendrocytes have a lot to do with myelin, right? So myelin's not going to stain on it very well because it's like fat. So you could see that. So that's how I try to remember those. Or you want to remember the fried egg appearance. That comes up a lot. So fried egg appearance there. Yeah. Frontal and temporal lobes. All right, ependiomas, right? The ependymal cells line the ventricular cavity. One of the important things about this is that it has a correlation with NF2, neurofibromatosis 2. Now that's different from NF1, where you get the cafe au lait spots and stuff like that. NF2 primarily has to do with its correlation with ependiomas. Okay, so you're still going to get the neurofibromas, but there's a good correlate here. Now, these are these rosettes that they find, these overcells. So you can see this around, so these gland-like structures between the lumens. So you see these gland-like structures. So these are these rosettes, or pseudo-rosettes as they call them. So that's a good way to remember it here. So this is a vascular structure and you get these pseudo-rosettes around it. Again, probably could get away with just knowing these rosettes is classic, but when you get to STEP, they're going to start just giving you pictures like this and you're going to have to pick it out. All right, embryonal tumors, medulloblastomas. So we're talking about pediatrics, so we're thinking infratentorial. So whenever they give you a medulloblastoma, you're thinking somewhere around the cerebellum, maybe a little bit superior to it, but you're over there. Fair game, this catenin pathway, or the MYC overexpression, I'd say so. All right, so again, small round blue, typically that means that it has some sort of neuroendocrine. These small round blue cells typically tend to be neuroendocrine, like small cell cancer of the lung, small round blue cells. And these form rosettes as well. So knowing that. All right, so meningiomas attached to the dura mater, you could see that, but it actually doesn't involve the dura mater, it's below it. So you could see here some of the good correlates that you should know. Schwannomas are involved, NF2 also involved, right? And then you can actually get multiple meningiomas. Big thing here, you see these clusters. These are Psammoma bodies in the brain. They're basically calcium, these world-type clusters, meningiomas. And then you get schwannomas, right? So we're talking about vestibular typically. So in the vestibular portion of the 8th nerve typically falls right around that, the pons area where that 7/8 nerve is. It can involve the facial nerve, but vestibular schwannomas, you can see here, also associated with NF2. Okay, Antoni A, Antoni B areas, I'd say fair game, knowing that. And if you can see here, I did write what NF2 involves. You can get it. NF2 is related to ependiomas, meningiomas, and schwannomas. Okay. And I would, when you look at these tumors, I think looking at first aid is a good way to kind of differentiate these things with these buzzwords. Okay. So definitely knowing these. All right. Is that whole lecture? Yeah. So don't freak out. I don't know that they're just going to give you a pathological picture. Like I said, this is more like studying for STEP, UWorld questions. But on the exam, you may get away with just knowing Psammoma bodies, pseudo-palisading, rosettes, stuff like that. All right, drugs of abuse, we will do quickly because everybody, if you know how the drug works, what kind of features show up on the drugs, then you know what the withdrawal symptoms are, okay? So if you're talking about some sort of stimulant, cocaine overdose, you're gonna get dilated pupils, you're gonna get sweating, all that stuff. But if you get, so withdrawal, you're going to get meiosis, constricted pupils, sedation, stuff like that. Okay, so just know, depending where the patient's at, did you just find them at a party? Did he overdose? She overdose? Or has it been a couple of days? They're coming off of alcohol or whatever. Okay, so just know the differences there, but I'm pretty sure y'all are good with that. Right, of course, the pathway, the nucleus accumbens, the reward center, the dopamine center has to do with this whole idea of addiction. I don't think they really asked too much about these. Yeah, but I guess if anything, knowing the molecular target is a good thing, right? You should know those, where they all work. Most of them have their own. PCP is NMDAs, right? And of course, how they work, right? So, oops, blocks dopamine, all these stimulants, blocks dopamine reuptake. All right, ethanol works all kind of places. Withdrawal symptoms, remember, 1 to 2 days out, seizures, hallucinations, and then 48 to 72 hours, you get a DTs. I believe, I'm not sure if benzodiazepines specifically fall into this category, but ethanol is one of, if one of the only drugs that you can actually die from going through withdrawals. I think benzos may fall into that category too, but stuff like cocaine, heroin, it's really bad withdrawals, but you don't necessarily die from it. The withdrawals, alcohol is one of the differences there. Okay, so you need to know what to treat them with if you're going through withdrawals. Giving them some sort of benzodiazepine, ethanol is good for that. So you can see this is good little tricks. Oxazepam and lorazepam, okay for the liver. So why would you worry about that? Because people that drink a lot of alcohol have liver issues. Okay, so giving that will be helpful. Now, if you're going to talk about alcohol addiction, right? Disulfiram is that drug that blocks aldehyde dehydrogenase. So what you get is if you drink alcohol, you get a bunch of acetaldehyde, and that makes you feel like makes you feel awful. It basically makes you feel like you have an instant hangover. Now naltrexone is an opioid antagonist, so you don't get the craving for alcohol. Now, I did get a UWorld question that asked about this, and like they said, what was the first line? And I put disulfiram because I was like, for alcohol, for preventing alcohol relapse or whatnot. And I put that, and they said, actually, naltrexone is considered the first line drug for that, because disulfiram, listen, if somebody wakes up that day and they're like, I'm gonna drink, they just don't have to take this medication, and then they'll be fine. So also, if you do take disulfiram and you were to drink alcohol, acetaldehyde is really bad for your liver. So I think the convention is now that disulfiram is second line as a preventative measure, but naltrexone is considered first line. You could use acamprosate as well, and that will prevent relapse. Now, for this testing purposes, I would think knowing these would be important. I think these are tests. The fact that disulfiram is for aversion. All right, if you drink it, you're going to feel terrible. Now, naltrexone is considered for craving. Okay, opioid antagonist, that craving, that reward center. And acamprosate is for relapse. Now, I think in reality, it gets a lot more convoluted or complex than that. But knowing which words kind of go with each should help you on the SGU exam. All right, and you can see here, if you block acetaldehyde dehydrogenase, you can't get the acetate. So you get a buildup of acetaldehyde, and that's problematic because you feel really bad. But again, this causes a lot of liver damage. So, you have to weigh the cost benefits as a physician. Flushing, tachycardia, hyperventilation, right? And then it goes through the different pathways. You can do this on your own, but basically we're inhibiting or antagonizing GABA and stuff to get this dopaminergic impulse to the reward center. And that is the principle of what addiction is. Okay, and then you can see here, if you were to take ethanol, naltrexone does not give you that feeling of reward, that feeling of doing something I like, right? So you don't get this dopaminergic response. You're still drinking alcohol, you still get drunk, but you don't feel that high, I guess. Okay, and again, before we get to this, if someone comes in with alcohol withdrawals, if they're going through DTs, if they're having hallucinations, give them a benzodiazepine, okay? That'll calm them down, help them get through it. All right, now we get to benzodiazepines. Now it says right here, so alcohol and benzodiazepines, these are considered not, opposite of stimulant, but like downers, right? They're sedators. I forget the exact word for it. But both of these can be life-threatening with the withdrawal symptoms, okay? And yeah. And what was the drug we used if someone comes in with, starts with an F? Anybody? Benzodiazepine overdose? Flumazenil, exactly. And what was the other one we talked about? What if it was a serotonin overdose?
Cycloheptadine.
Exactly. Very good. Yeah. So those will come up on your exam. So good. All right. Opioids, right? So these are also considered in the sedating realm. So heroin, morphine, codeine, oxycodone. Codeine is converted to morphine. Fentanyl as well, highly abused. But again, same principle. You're directly activating this dopamine center, this reward center. So tolerance, dependence develop. Now, when we talk about withdrawal, so patient comes in, let's do intoxication first. Patient comes in intoxicated. You would expect pinpoint pupils, right? If they're on heroin, a lot of opioids or whatnot, you would get pinpoint pupils. Now, if they come in withdrawals, you would expect the opposite. So the eyes is a big clue of what's going on. So if the eyes are dilated, that's a big clue for opioids that they're going through withdrawals. Now, a big one is yawning. I don't know if y'all watched that show Euphoria. If you do, you know what I'm talking about. But yawning's a huge one. If the patient comes in yawning, that's a sign of opioid withdrawal. So lacrimation, rhinorrhea, I think that's a good picture. Yeah, look, so lacrimation, rhinorrhea, yawning is opioid withdrawals, okay? So detoxification, methadone clinics are big for, to prevent people from doing heroin. So this is how it works. So if you look at heroin, for example, you get these very rapid spikes, you get these highs, but you also get these very bad lows. So to counteract that, people are given methadone. You don't get those highs or lows, but it keeps you from going through withdrawals, okay? So it's a longer acting. Is it a perfect system? I don't know, we don't need to get into that, but it's a means to an end, right? You're preventing people from doing heroin, and that's a good thing in and of itself. All right, now, detoxifying using opioid antagonists. Now, Trexone is antagonist with high affinity, specifically for the mu opioid receptors. And the mu receptors are the ones that cause the big problems. The mu receptors are what's caused the respiratory depression. And that's what we worry about with opioid intoxication, primarily that respiratory depression. So now Trexone can be used for that long-term, right? I believe it's naloxone is the one. So if somebody overdoses on like heroin or whatnot, I don't know, did they not talk about this in here? Right, that's where like they give them intranasal spray, and it's an opioid blocker as well. So now Trexone is more of a long-acting effects. So after detoxification, right? So if you want to remain opioid-free, you can take an antagonist, naltrexone. But if you're not familiar with naloxone, go look that up on YouTube and see how that works. Like it literally, like if somebody's down and they have respiratory depression, they're like overdosing on heroin, they give it instantly intranasal and they come out of it immediately. And they're very upset because you messed up their high. I don't know. I've seen it on TV and stuff. It's pretty crazy.
I think naloxone is just like what they have in the ambulance, right? Like EMTs.
Yeah, exactly. Yeah, so they just intranasal and the patients wake up, they don't know what's going on. And, yeah, it's pretty crazy. Yeah. Inhalants, not super important. I guess kids get into that. Y'all don't talk about it too much here, but nitrous oxide, yeah, you can do that. You have to worry about that. So you know how nitro works. So You get that vasodilation and whatnot, venodilation, and then, yeah, depending on what it is. So like amyl nitrate or poppers, non-addictive, but you know, yeah, used to enhance erection, nitrates, venodilation, right? So that's the whole idea there. And then we get into the stimulants, right? So uppers, right? Cocaine, primarily all of these inhibit reuptake with dopamine, norepinephrine, serotonin, depending, you know, on what it is. So you intense euphoria, you have more of dopamine available at the cleft, right? And y'all kind of know all this already. So amphetamines, yeah. So methylphenidate, stuff like that, stuff for ADHD fall into the amphetamine categories. And yeah, so same principle, inhibits reuptake, norepinephrine, serotonin. So you have, you know, this is an amphetamine response. So you get more levels of neurotransmitters in the cleft. Let's see, yeah. High dose, you can get psychosis, which you would expect, same thing as with cocaine. Right, and there's a treatment for, I think for narcolepsy, they tend to use modafinil instead, but this can be treated. I don't know if we even talk about modafinil here. I think it's better tolerated, less chance of, anyway, if they don't talk about it, don't worry about it. But yeah, that's another option as an amphetamine. Right, then nicotine, y'all know about this as well. It has its own receptors, this nicotinic receptors. Dopamine is released when you excite those receptors. Okay. Euphoria, relaxation, appetite suppression. Yeah, okay, so, but y'all have seen these a lot. Bupropion, remember we talk about that as a norepinephrine dopamine agonist, helps with the release of that. This can be used to help with smoking cessation. Varenicline is Chantix, I believe, but you see the commercial, this stuff has, like the end of the commercial is like 20 seconds long with side effects. Like it's like suicidal ideation after taking this. But I think the idea here is that you can still smoke while you take varenicline, like the first week, and it kind of decreases your cravings. So it's like this novel effect that they try to use. The reward system kind of slows down, but it allows you to continue smoking. So people are more, you know, not as averse to trying it, okay? Then caffeine falls under the methylxanthines, phosphodiesterase inhibitors, or not phosphodiesterase. I don't know, it improves CAMP, adenosine, blocks adenosine. It may be phosphodiesterase, don't quote me on that. What does it say? Okay. Right, so it increases norepinephrine release. Okay, these methylxanthines. Yeah. All right, and then hallucinogens, marijuana falls under that category. You can read about that here. Dronabinol is the prescription version of it. You can use, right, disinhibition of dopamine neurons. Again, y'all know all this already. If someone is, you know, not on marijuana not coming down, but they're stopping taking marijuana, they may get appetite suppression because obviously marijuana causes you to get hungry and stuff. So just be wary of the question, what they're asking. Are they intoxicated or are they withdrawing, right? Because then you can differentiate what's going on. And nausea and vomiting is a big one for treatment of cancer chemotherapy, right? You can give dronabinol or whatnot, or medicinal marijuana. LSD, these don't fall under, you know, something that is technically, oh goodness. You're right, so you don't get that dopamine reward, so you can't really get, they say you can't get addicted to it. Addicted is the word I was looking for, right? So, but you can read in here how they kind of work. Antagonists at the serotonin receptors in the brain, right? So here we go. No withdrawal syndrome, do not cause addiction, but you do develop a rapid tolerance. Again, these questions on the exam should be pretty straightforward, okay? MDME or ecstasy, right? Can cause serotonin syndrome at high doses, but you know, the idea here, these are stimulants as well. I guess it falls under a hallucinogen, but I think it'd be considered a stimulant as well. It is an amphetamine. Okay, now PCP, angel dust. The word they usually use for this is belligerent. The patient comes in belligerent, okay? And it is an antagonist at the NMDA receptors, glutamate, but the patient just comes in just, you know, ready to fight in the ER, you know, no worries about anything. But the word, whenever I think of PCP, I think of belligerent. And also one of the defining characteristic clues is that they have a nystagmus, right? Their eyes start twitching. So violent, bizarre behavior with a nystagmus, PCP. That's what you're going to go with. Dilated or constricted pupils. So that's very, that is one of the characteristic things that you can use for other intoxications that you can't use here. So, but you can still use the eyes. The nystagmus is the big one there. All right. Sedate them, give them a benzo, they'll come out of it. All right. Now I put this in here just to show you guys that the only thing you need to know about, in my opinion, this is just my opinion, but the only thing they ever ask about is St. John's wort, okay? Right, and the problem is that it works as an inhibitor. So it can be a mild MAO inhibitor, you can see there, but it is, but it technically falls under as enzyme induction, right? So let's see. Right, wait, do they have a slide on it? I guess not. Anyway, it is an inducer, right? CYP inducer.
Yes.
Okay, just making sure. Okay, yeah, so that's pretty much the only question that they ask about that. Okay, it is over the counter, which is what makes it problematic because people don't realize that they're taking my other medication. It'll induce the medication, so the medication won't work as well. It'll be metabolized fast. All right, toxicology. I know this is very dense. We're not going to go through it all. I just want to point out the stuff that they'll probably ask you about is the stuff that people will actually overdose on. Okay, so you're not going to be in the ER and somebody comes in with an overdose of like cadmium or something like that. Okay, so don't stress on stuff like that. But they might, somebody might come in with like cyanide poisoning. Okay, so understanding how that works is a good test question. Heparin or warfarin or things like that are good to know. So, knowing that is a good way. Knowing that should be enough. Like, don't trip out on some of these that are not very testable. All right, 2 more and we'll be done. I wanted to go through these general anesthetics. It's not so much the drugs that they like to test on, it's these properties of the drugs, okay? So we'll try to go through these. I know it's a little bit confusing. Right, so for these inhaled, there's IV versus inhaled anesthetics, all right? So we've talked about the pharmacodynamics of these inhaled anesthetics, right? So minimal alveolar concentration, okay? That means what is the lowest amount of drug you can use to get an effect, okay? So if it has a low MAC, that means that it's a very potent drug, okay? What is the minimal amount you can use to get an effect? If you can use 1 milligram, this is obviously, it's different for anesthetics, right, that are inhaled. But for example, if you can give 1 milligram of a drug versus 10 milligrams, the one that's 1 milligram has a higher potency, right? A lower Km, right? Same principle here, minimal alveolar concentration that you can give, right? So you can see here, this has a very high potency. It has a low MAC, okay? High potency equals low MAC. That's a little, you only have to give a little bit of this drug to get into the alveoli to make it work. Whereas nitric oxide has a very high MAC, okay? That's the first thing. Now, there's also this oil gas partition coefficient. So they are inversely proportional, okay? As the oil gas increases, the MAC decreases. So What does that mean? Okay, so the oil is in the numerator, right? So think about a drug that is an anesthetic as a gas. If the denominator, which is the gas, goes up, then this value is going to go down. The oil gas coefficient is going to go down. Okay, so as this increases, the MAC decreases. So I guess the better way, they put it here, right? So the more you have in the oil, the more potent it is versus the gas form, because this is the numerator, this is the denominator. So if it helps you to work these out, I think long-term it does, but maybe just for the exam, just knowing that they're inversely proportional. So, but what I'm trying to say is that a low MAC, a low minimal concentration would imply that you have more in the oil form than the gas, right? Because it's oil to gas ratio. So more oil than gas would imply that it's a very potent drug. I'm trying to harp on this because this is very different from the induction of the drug, which is what's coming up next. So minimal concentration means it's very potent. It's very potent if it has a lot in the oil form versus the gas, okay, this coefficient. And you can see kind of how that works here, right? Now, when you get to induction of the drug, there is another, okay, so it's an inverse relationship here. So if it has a low blood gas coefficient, that determines it's the faster onset. Now, what does that mean? If it has a lower coefficient, that means the gas, which is in the denominator, is higher, right? Okay, so wouldn't you expect a drug that you're giving, you know, in the air, you know, you're giving, you know, inhaled, you'd want it in the gas form, right? Not in the blood. So if it has a coefficient where more is in the gas form, the onset's going to be quicker. Okay. Whereas if it was in the blood form, it may take more time to get out of the blood, right? If it takes more time, it'll take a longer onset of action. Whereas if it's in the gas form, it's in the denominator. This denominator is a high number. The value is going to be lower. Okay. So you're going to have a faster onset of action, meaning once you get it through the blood, it's ready to pop out of the blood and go into the tissues, into the gas form. Okay. That's at least how I wrap my head around it. So you can see this blood gas form, nitrous oxide, most of it is in the gas form. Okay. So when you inhale it, it's diffused through the body. It works faster. Whereas methylfurane, longer to leave the blood. Because if you go back, it's in that oil form. Okay. It has a low concentration, but it takes longer to act. So if that's still confusing to you, I don't know if I did a really good job explaining to it, but that's how I try to wrap my head, the numerator denominator thing, like what is preferential there. But they did put this. So worst case, just know this, low MAC leads to a high oil gas coefficient. So this correlates to high potency, okay? And if you have a low blood gas, that is faster induction. So let me try one more time, see if I can do this. All right, so MAC means that's your concentration. You can give a very low amount of this drug to work. That means it's very potent. Now, this number is very high. So if this is numerator, this is denominator, the oil form of the drug means it's very potent, okay? It's not going out into the gas. It's a very potent drug. Little bit of drug, very potent in the oil form, preferentially. Whereas when you talk about induction, meaning how fast is the onset, this nitric oxide is a very low number. That means much of it is in the gas form, the denominator. Okay, so if that's the case, it's going to want to get out of the blood, get into tissues, get into the brain, work fast. Okay, so whatever works for you. It's just this still holds true in my head for whatever reason, you know, just studying for STEP and stuff. So, but whatever works for you guys, go for it. All right, so that's primarily what they really ask about in regards to these questions. Let's see. There were a few things. Let me just read through this and see. No. I think it has to do with the IV drugs that they ask about, which is coming up. Right, so halothane, hepatotoxic, that's a big one. Halothane's commonly used, and you know, halothane and succinylcholine is problematic with malignant hyperthermia as well, right? Oh, here it is. Yeah, halothane, succinylcholine can cause malignant hyperthermia. People have a genetic disorder that can happen there. So typically this happens their first time they undergo surgery and they have to go under anesthesia. And yeah. And it causes, yeah, you should remember this from early on, the ryanodine receptor gene, it causes a massive influx of calcium. So the muscles tense up and you get hypothermia, and it's a medical emergency. It kind of goes through how it works. And then again, just like neuroleptic malignant syndrome, you can give dantrolene, which will block the calcium release, okay? Okay, muscular dystrophies. I don't know why I started talking about that. Okay, and to diagnose it, if you were to try to diagnose the possibility of getting of that autosomal dominant gene that can cause malignant hyperthermia, they do the caffeine, halothane, muscle contracture test. Yeah, if you wanted to check for that, if you had a family history of it or something. Okay, chronic toxicity here, hematotoxic, toxic to the blood. All right, so then they get into the intravenous anesthetics. Some of these have very different properties, so it can kind of determine what you want to use. If it's a very quick procedure, you could use thiopental or the methotrexate. I think this would be the one that they would talk about more often. Yeah, so they're very short acting. Like if you needed to set a bone or something like that, you can knock somebody out real quick, set the bone, and they'll come out of it pretty quick. So these are those barbiturates you can use. Propofol, everybody knows classically, Michael Jackson. So here's some of these properties that are very specific to it. It has no analgesic properties, okay? It will knock you out, but it will not help with any of the pain, okay? Yeah, potent respiratory depressant, okay, that's problematic, okay? But the no analgesia, I think, is the one thing that stands out for that. Also, you know what it is? They all have no analgesic effect except ketamine, I believe. Yeah, ketamine will have this IV anesthetic effect. Okay, so propofol won't, etomidate won't, but versus propofol, you could see that etomidate doesn't, if that's how you say it, minimal CV and respiratory depression, okay? Adrenal suppression with prolonged infusion. And then of course, ketamine can be used if someone wakes up from anesthesia, just hit them with ketamine, it causes dissociative amnesia. They won't remember what was going on. Catatonia, amnesia has that analgesic property as well. Right, so you could start that. Only IV anesthetic that has analgesic and produce cardiovascular stimulation. Okay, so if you are worried about some sort of patient with congestive heart failure or whatnot, and you need to maintain cardiovascular, the pump to work, circulation, then you can use ketamine. Okay. Vivid dreams, yeah, that has to do with the dissociative amnesia. All right, and then of course you can use adjuvant along with it, benzodiazepines with the anxiety, maybe give it to someone prior to surgery, opioids for the analgesia if you're using like etoposide or a propofol, because it doesn't have these analgesic effects. You give opioids, neuromuscular blocker, relaxation, something like that. And then Zofran or ondansetron is great for anti-emetics, for chemo or post-op nausea. All right, anti-muscarinics, scopolamine, right, primarily used for motion sickness, but the point is you don't want to have too much muscarinic effects, so you can prevent salivation, bronchial secretion, glycopearly. This actually came up as a UWorld question. I got it wrong. I didn't remember this one. So some of these are fair game that you think you never see again. And then if you're worried about too much bradycardia for one of these agents, atropine is an antimuscarinic as well, okay? All right, I know it's very dense. I hope I did okay with explaining because it really does come up. Let me just show y'all. This is important, okay? So first two columns deal with potency. Low MAC, high oil gas means it's potent. No, you know, I don't know if you need to know all these, but you should know some of these ones that are on the terminal ends here. And of course, the blood gas has to do with induction, how fast it works. Remember, if it works fast, it wears off fast too, okay? It's a good thing to know there. All right, one more. All right, so local anesthetics first. Basically lidocaine, right? Lidocaine will block the sodium channels so you won't get depolarization easy enough. I can't remember that I did make a point of writing these out during lecture, or excuse me, or during my post read. I don't know that they really asked this stuff, but like which ones fall into which categories. But there was a trick, right? So whichever one has two I's in it is an amide versus the esters, right? So two I's, two I's, two I's. Yeah, and again, you don't need to know these molecular structures or anything. Right, so again, lidocaine is the primary example, blocks sodium channels, right? On the outside, you don't get depolarization, right? Okay, liposolubility has to do with potency and duration of action. So the more liposoluble it is, the more it's going to diffuse through the adipose tissue and whatnot, the harder it is for you to get rid of it out of your system, okay? Remember, liposoluble drugs are not going to be cleared through the kidneys. It needs to be charged to get through the kidneys. So if it's liposoluble, you're going to have a decreased clearance, increased volume of distribution. All right, so yeah, closer to pKa, the body pace, faster the onset, you can make it charged, just take off a hydrogen or whatnot. Once it goes through the liver, and then it's faster onset, faster clearance. All right, now what they like to do when they give lidocaine is they give epinephrine with it. What that actually does is it constricts all the vessels around this little area. So if you're trying to suture up an area of the arm, you can give lidocaine with epinephrine. So the lidocaine will help to numb the area, right? Block the depolarization of the sodium channels, and the epinephrine will kind of constrict all the vessels around it so that the lidocaine stays centralized. It prevents any problems with the lidocaine diffusing through your body. But more importantly, if it's centralized, it tends to work a little bit longer, right? You're just not going to just kind of diffuse out. Okay, so that's a very important principle that they do there. All right. That's a fun fact. These alpha-2 adrenoceptors, which is inhibitory, help to inhibit substance P. So that's kind of like a dual effect there for the pain. P for pain, that's how I remember that. They used to use cocaine in this regard, but not so much anymore, right? Because it's a potent vasoconstrictor. All right. And again, I know I'm skipping through some stuff. At least for our exam, that's all I could speak for. These drug things, the drug questions, they were pretty, it was fair. It was a fair test. Okay, so like I know they could have made it a lot harder, but I thought it was pretty fair considering the amount of material. So I'm trying to just cover the stuff that stands out to me as being important. Okay, so anesthetics, short acting, intermediate. I'd say medium yield, low yield, not super important. All right, and then the toxicities, right? As you would expect, if you're blocking stimulation, depolarization, right, to stop pain, if you don't use epinephrine and for some reason the lidocaine or whatever you're using gets through, you can get CNS depression, respiratory failure, right? And large doses, you can even give some sort of benzodiazepine to prevent against seizures, okay? So this seems like very, very rare occurrence that this would happen, you would be able to prevent this with pre-treatment. All right. So let's see. Sorry, my computer's. Go back. Hold on one second. Okay. All right. So again, classically, these local anesthetics block sodium channels. If you're able to give epinephrine with it, you can vasoconstrict the area to prevent any the medication, the lidocaine or whatnot, to go anywhere else. All right, okay. And again, depending on how much you actually give, that could lead to this. But once again, if you control where you keep the medication with vasoconstrictors, you can limit this problem. But I guess it really depends on what area you're working on. Yeah. Right, so this is that folate pathway. I don't remember them asking about this though. Now we got into the skeletal muscle relaxants. All right, so there's neuromuscular blockers, and then there's versus so non-depolarizing versus depolarizing, which is basically just succinylcholine, and then there's spasmolytics as well. All right, so basically there's non-depolarizing, which prevent the sodium from coming in. It makes sense, you can't depolarize. And then you have depolarizing blockers, as once all of the sodium comes in, then it prevents it. So it has to be depolarized first, and then once you get to that point, you can't. You have to give another agent to have it repolarize, and that's basically succinylcholine. These are the non-depolarizing blockers, so they're going to block that sodium. Yeah. I don't remember much of this being very high yield. Oh, here, that was one thing. Okay, so Bivacurium is very unique in that it's not metabolized by the liver or the kidney. So it's a very short acting medication. So things that tend to be metabolized by the kidney are going to have longer half-lives. Metabolized by the liver will have shorter half-lives. Okay, so right, so you can see here, since Bivacurium is not metabolized by liver or kidney, it actually uses plasma pseudocholinesterase. I would know that for sure. It has a very short acting. But again, the ones that have renal tend to be keep longer because they have to be charged in the charged form. And then the liver have shorter half-lives because you can inactivate them. Yeah, so again, here it is. Plasma, that's not the word they used before. Pseudocholinesterase, right? That's how it's broken down. So Bivacurium, very short acting, not dependent on the liver or the kidney. All right, and then our main depolarizing blocker, succinylcholine. Remember, it is problematic with malignant hyperthermia as well. Get that, give dantrolene to alleviate it. All right. Activates nicotinic receptors, depolarize it. So you get these initial fasciculations. So the membrane stays depolarized. So you can't get any other responses. It stays at baseline. So until the drug wears off, or you give a reversal agent. Yeah. And then some adverse effects. Again, I don't remember them testing us a lot on this. This is histaminic effects. I just think this test has so much material on it. They kind of picked and choose what they felt was important, and they didn't really feel like this was too important. I think anesthesia gets a lot more complicated than what we're getting into now. So again, if you have nicotinic responses here, like such as succinylcholine, right, that depolarizing agent, this ganglion blocker, you can in both sympathetic and parasympathetic, and then muscarinic receptors in the heart as well. All right, so be careful with stuff like this, malignant hypothermia being the main thing there. All right, right, no CNS effects, can't penetrate the blood-brain barrier. All right, and then here's some of, if y'all are into charts and tables, that is there for you. Some drug interactions. Y'all have learned about MG before, increased neuromuscular blockade. Yeah. So these are very rare occurrences. I don't think that's super high yield either. And what you would use it for. So succinylcholine, remember, if you can depolarize the cell, you get this flaccid paralysis that makes endotracheal intubation easier. Okay. And then reversals. So since it's depolarizing, if you need to bring the patient out, you can give a reversal, neostigmine, edrophonium, to reverse the competitive blockade, right? So to increase your acetylcholinesterase. I'm sorry, to inhibit acetylcholinesterase to inevitably increase acetylcholine. And then you could also give antimuscarinics, primarily atropine to prevent bradycardia. Glycopyrrolate is more selective for like saliva and stuff. So atropine would be what you want to give there if you had to. Then the spasmolytics, right? So diazepam, GABAs are good there. Baclofen, same thing for GABA. And tizanidine, agonists at alpha-2. Remember, alpha-2 is GI, so it does have this inhibitory effect as well. Big question they could ask here. Halothane, succinylcholine given, they undergo malignant hypothermia, they're tonic contractions, they're overheated. Give dantrolene, you can help to alleviate that massive calcium influx that's caused in malignant hypothermia. Botulism toxin obviously prevents acetylcholine presynaptic release. So for generalized spastic disorders, yeah, you can give that. All right. And again, I know these are just drugs and I'm reading off the slides. Unfortunately, I don't have much more for you. A lot of this stuff is just memorization. Some things are just, more testable than others. So I hope I was able to point out some things for you guys. We'll look at the MSK and the infection stuff tomorrow. A lot of it will be similar. I'll point out some of the things that are more commonly tested, especially with the antibiotics. But unfortunately, it just comes down to a lot of memorization. So anyway, good luck on your OSCE. Good luck studying. Y'all can always reach out to me. If y'all need anything, same time tomorrow, 10 a.m. We'll go through the rest of the stuff. Sound good?
Brady, question, because
Sure.
they were really bad and gave us like 2 practice sets for like the anti-parasitics and like the bone morphogenic, the bone drugs like a couple days ago, even though they were a couple weeks old for like when we went over them. How heavy were those? Because like only giving anti-parasitics is impossible at this point.
That I really feel like they tested on the more common things. Like it was first line drugs, like those 1 or 2 things that you would remember from the the parasites. And even for the bone stuff, like bisphosphonates is highly tested. But other than that, yeah, that's, I was pleasantly surprised when I took the test. I was like, they really could have screwed us. And it wasn't so bad. Now, granted, that doesn't mean much for you guys, but I thought it was okay. I thought they actually sat down and were like, this is a whole lot of material. We're going to try to keep it fairly straightforward.
And same thing with the antifungals, because they only gave us like 4 practice questions.
Yeah, like give those azoles, fluconazole for everything. I don't know. Yeah, it's pretty much. Yeah. Yeah, so it'll be pretty straightforward, I think. At least
Okay,
it was for
thank
us.
you.
All right, cool. All right, I'm gonna close the session. I'll see you guys tomorrow.